One thing, Partho, the speaker's introduction, would there be slide from your side?
Yeah, there will be slides. There's a system of projection, so
Right.
don't worry about it. ঠিক আছে না? Well, I think it is it is dot 6:30. We'll start now. Good evening, everybody. Welcome to the 8th module of PULMOCON 2020. This module is specially prepared on sleep disorders. It's my pleasure. We have got a fantastic galaxy of faculties. The whole session will be chaired by Dr. DJ Roy, who is a known pulmonologist and a proponent of sleep medicine in Eastern India and India altogether. He is presently a consultant in the Parkview Super Specialty Hospital. But before I hand over the responsibility to him, as the organizer of PULMOCON, I welcome all my faculty, Dr. Deepak Srivastav from US, Dr. Vikram Sarabhai, my good friend from UAE, Dr. Uttam Agarwal from Kolkata, Saurabh Das from Kolkata, and our dear Dipankar from Kolkata, and the coordinator of the session, whom you all know, Arup, is from Kolkata. Now, I have left everything to Arup, and Arup actually is holding the whole show, and my job is over. Now, I'd like to hand over to our chairperson today, Dr. DJ Roy. Dr. Roy, please.
Yes, thank you very much. Thank you, the panelist. This is a session on sleep disorders, and particularly on obstructive sleep apnea. And this session we will conduct in two parts. The first part will be the session on diagnosis and treatment of obstructive sleep apnea on a case-based basis. And the second part will be some interesting cases that will be presented by the speakers. Let me first start the first part. And I hereby introduce, please slide please, the speakers. First speaker is Dr. Uttam Agarwal. He is MBBS, DLO, DNB, ENT, and MNMS. He's a dynamic ENT surgeon and sleep medicine expert. He has special interest in rhinology, sleep medicine, particularly sleep apnea. Chief ENT surgeon and director at Orange Dental and ENT Care Center. He is a recipient of Rajiv Gandhi Excellence Gold Medal in 2019 for outstanding contribution in medicine and research. Dr. Uttam Agarwal will speak about the history and clinical examination of a case of sleep apnea, how to proceed. Dr. Uttam Agarwal, please.
Thank you, sir. Thank you for the kind introduction. A very good evening to all the attendees. It's been an honor and privilege to be a part of the PULMOCON, and I feel very proud to be here, and a special thank to the whole team of PULMOCON, and especially Dr. P.S. Bhattacharya for giving us this opportunity. So without much ado, let me start the case. So this whole module has been divided into 4 parts, and I'm going to represent the first part, which is history and examination. How do we approach a patient with sleep apnea? I hope my screen is clear.
Yes, it is clear.
Sure. So what if a suspected sleep apnea patient walks into our hospital? How do we assess? So from our UG days, we have learned the importance of history, and we have to take a detailed history from the patient about his daytime and nighttime symptoms. Most of the time, the patient's history is not sufficient, and we need a history from the companion person, be it wife, husband, or parents. And at times, we need a sleep diary to rule out insomnias. So in the daytime symptoms, there's a long list of leading questions which we can ask to the patients. So start from excessive daytime sleepiness, whether there is a non-restorative sleep, a morning headache, tiredness and fatigue, memory loss, cognitive deficits like irritability or loss, short-term memory loss, personality and mood behavior changes, loss of libido, sexual dysfunction, and GERD. In our patient, we had excessive daytime sleepiness. The patient also complained of non-restorative sleep, tiredness, and fatigue. For the nighttime symptoms, we often bank on the patient's companion person about what the patient goes through during the night. So these are the most common symptoms which we usually ask the patients. So maybe a loud and regular snoring, whether there was any witnessed apneas or not, whether there is any abrupt awakening with a sense of gasping or choking during the night, and nocturia. In our patients, the first three symptoms were present. The patient complained of loud and regular snoring. Witnessed apneas were seen by the wife, by the husband, and there was many incidences of abrupt awakening during the night. When the history is not very clear, and the patient says, I also have some, I take some time to go to sleep. When the sleep history is not very clear, sometimes we ask the patient to maintain a sleep diary. This is a common performer what we follow. So patient has to fill two forms, one in the morning and one in the night, and they will fill everything, what time they have gone to sleep, what time they have woken up, how many times in the night they have gone to the washroom, and was the sleep disturbed, and how do they feel when they get up in the morning. Same way they have to feel during the end of the day, whether they are taking any naps or not, how long was the nap, and how much caffeine they have consumed, and so on. Along with this, we have to take a detailed history about the medical history and surgical history. We have to take whether the patient is on any drug, whether there was any hypertension, diabetes, or other metabolic disorders, and detailed history is being elicited. In this patient, we have got a history of uncontrolled hypertension, which was noticed. After the history part is over, we give the patient, from the history only we can make out what are the chances of having the patient a sleep apnea disorder. And after the history, we will go for the questionnaires. The first and most common questionnaire what we use is a stop bank questionnaire, which has got 8 points into it. So the stop bank itself stands for snoring, S stands for snoring, T for tiredness, O for observed apneas, P stands for blood pressure. If the BMI is more than 35, A is more than 50, neck circumference more than 40 centimeters, and gender male. So each of this point has got 1 point if the patient says yes. So for everything, if the patient says yes, we'll give a 0.1, and if they say no, it is 0.0. This is very simple, replicable, and very easy to do test, which will take a minute or two. And this is highly sensitive. So a score of more than 5 has got a very high chances of patient having severe OSA. So in our patients, the patient do fill the form, and there was a snoring, there was tiredness, there was a witness apneas, high blood pressure, which was uncontrolled, and a neck circumference of 40 centimeters. So being this test, this is highly sensitive, and there's a high risk of having a severe OSA in this patient. The next questionnaire which we ask the patient to fill is a first sleepiness scale. This is basically to know how drowsy is the patient. So this doesn't give a very direct correlation with the OSA, but this gives us a very detailed insight about how much the patient is sleeping. Now, the patient can be sleepy for so many other reasons. So this has to be taken with a pinch of salt, because the sleepiness is because of some sleep deprivation, insomnias, metabolic disorders, or maybe patient has got some narcolepsy, PLMD, or some jet lag, some psychiatric diseases, or even maybe some drug history also. So the detailed history has to be taken before filling this first sleepiness scale. It has got 8 situations where the patient has to stand himself or herself, right from sitting and reading, watching TV, sitting inactive in a public place, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after a lunch without alcohol, and in the car while stopped for a few minutes in the traffic. Now, the patient has to fill from 0 to 3. So there are 4 points into it. It can be a 0 when the patient will say he will never doze off, and he will score as 3 when the patient will say there's a high chances of dozing off. So this format is a modified one. The ESS was made in the year 1990. It has been revised in 1997 with few changes. The clinical implication of this, the patient has a score of 0 to 5. We call it a lower normal daytime sleepiness. A score between 6 to 10 is a higher normal daytime sleepiness. 11, 12 is mild. 13, 15 is moderate excessive daytime sleepiness, and 16 to 24 is severe excessive daytime sleepiness. In our patient, we had a score of 10. That means patient has a higher normal sleepiness scale. So once this questionnaire is done and we are almost sure what we are going to get, we can proceed for the clinical examinations. The sensitivity, as I said, of stop bank questionnaire is very high. It's almost like 100% for a severe OSA patients, but it lacks in specificity, which is only 37%. But if we incorporate some morphometric data like electroencephalogram, then the specificity also increases to almost 98%. So with the detailed history, questionnaires, and a morphometric data, we can be sure of whether the patient has got sleep apnea or not. Usually we prefer taking the X-ray in a supine position because that will give some gravitational effect. And based on this, there are some points which has been plotted, right from the sphenoid to the nasion, the anteriormost part of the maxilla, the anteriormost part of the mandible, and we make some, we draw some lines from point S and A and S and B to find out whether the patient has got any retrognathia or some prognathism, and how is the posterior air space, and a lot of information can be known from this. So after a detailed questionnaires and a detailed history, we'll go for the examination part. So thinking in mind about the OSA, we'll take the patients in two ways. First, global, we'll see whether the patient's BMI is very high or not, what is the body weight index, body mass index, and we'll look also for the adipose tissues around the chin, whether the patient has got double chin or a very thick neck or a very too much of soft tissue in and around the face. And we will also go for the local examinations about the detailed anatomical examination about the nose. Even adult adenoids are very common, what we see in our practice, tonsillar hypertrophy or not, palate, tongue, or the position of the jaw. Maximum the patients will have an overlap of different parameters in this. So we will look for some static obstructions. These are easily seen and easily identified. So when we ask the patient to open the mouth, we can easily see hypertrophic tonsils. We can make about the deviated septum. We can see about the turbinate hypertrophy. Enlarged adenoids can only be seen with the endoscopes. And we also would like to see about the dynamic obstruction, but it is very difficult to predict about the dynamic obstructions clinically, because this is only present during sleep when the muscle tension relaxes. So the common organs which plays a role here is palate, tongue, and lateropharyngeal walls. The role of endoscopy, this is paramount importance while examining a patient who are suspected to be suffer from sleep apnea. Role of nasal endoscopy and laryngoscopy is highly crucial in this. So putting an endoscope in the nose to see the nasopharynx, whether it has got any adenoid hypertrophy or any SOL. We may miss some polyps in the nose by simple anterior rhinoscopy. We need to see whether the patient has got any nasal polyps or not. Similarly, with the laryngoscopy, we would like to see about the base of the tongue, whether there's any lingual tonsils or not, or there's any space occupying lesion, or in this case like valvular cyst, what we can see in this picture. So I will just give you a couple of examples which I've faced in last few months, where I've seen a patient. Patient is a known sleep apneic on Cpap trial, and he is not able to tolerate the Cpap at all. And this patient was dozing off while sitting in the chamber. And on putting the laryngoscope, I could see the whole epiglottis is folded up and completely covering the larynx. With a lot of difficulty, I can see a part of the larynx, which was very small area. On detailed history, it was revealed the patient has got a CA piriform fossa, for which he has taken radiotherapy, and this has resulted into a lot of fibrosis around the epiglottis, leading to closure of the larynx. So this is how the larynx looks on a very close view, and we can see some ulceration on the lateropharyngeal wall. And when we after the tracheostomy, which we have advised, and for the evaluation for the ulceration, the patient's EDS went off, the snoring stopped, and he did really well. Same way, this is second case what we have seen, huge valvular cyst, again a known patient with sleep apnea, and the patient was not able to tolerate CPAP at all. And this is the relevance or importance of doing a laryngoscopy before advocating any treatment for sleep apneic patients. So the airway evaluation is very crucial in patients, and we have to do a detailed examination of the nose and nasopharynx, oral cavity, hypopharynx, and also being a surgeon, we also do a staging of the airway. So in the nose and nasopharynx, we will like to see about the nasal valve, any deviated septum, turbinates and their hypertrophy, any polyps are there or not, features of allergic rhinitis, adenoid hypertrophy, hypertrophy of the salpingo folds, or whether there is any craniofacial or corneal atresia. In our patients, we have got only a gross DNS. Apart from this, there was nothing else which was very relevant in nose and nasopharynx. Similarly, in oral cavity and oropharynx, we have to look in detail about the dental anomaly, or whether there is any bite deformity, malocclusions, position of the jaw, and we have to make a note about the tongue, tonsils, and palate together. So for malocclusion, what we follow is mainly Angel's classification. This is basically divided into three classification, when the maxillary and mandibular arcs are in the same line, but there is either too much of dental displacement, malalignment, or spacing or crowding of the teeth. And just class 2 is basically when the upper jaw is little pushed forward and these are not in line, and this has been further divided into 2 categories. One is overjet, where the teeth are, upper teeth are projected too forward, or it is open bite, where the lower teeth is being covered by the upper teeth. And the third one is where the lower jaw is being pushed forward, and the upper is more like a prognatism. So this kind of malocclusion can point a lot about the jaw's alignment for a patient, which is very crucial for the posterior airway space. Again, the position of the jaw, we have to make a note about this, whether the patient has got any prognatism or any rectoneglism. The most common what efficiency in a patient is a malampati. I think this is very quite known to everybody from our UG days. This is mainly done by an anesthetist to ensure how much ease he is going to get while intubations. Here the patients are asked to take out the tongue and open the mouth fully, and we make a note about the different structures what we see inside the oral cavity. So malampati 1 is where we can see the whole of the tonsils, the tonsillar pillar, uvula, soft palate, everything. And in malampati 2, we can see only the base of tongue, base of uvula, soft palate, and the hard palate, with very little portion of the pillars. And malampati 3 is where we can see only the soft palate. This is highly, this is again a patient is jetting the tongue out, and this was further modified by modified into a modified malampati, where instead of 3 classification, there are 4 classification, and the 2 has been divided into two components. So one will be where we can see a part of the pillar and part of the uvula, and malampati 3 is basically where we can see only the base of uvula. Now, this malampati classification has been modified by Friedman palate position, we call it. And he has made 2 changes into his classification. First, number 1, the patient is asked to put the tongue inside. He's not allowed to put the tongue outside. And there are 4 categories instead of 3. So he make a note of the position of the tongue with respect to the palate. He also make a note about the tonsil size and also about the BMI. In this, we can see in the Friedman palate position, the palate Friedman FPP we call it. FPP 1 is where we can see the whole of uvula, tonsil, and pillars. 2 is when we can see uvula but not the tonsil much. 3 is where we can see the soft palate with a very small glimpse of the base of the uvula, and 4 is where we can see only the hard palate. Same way the tonsil has been graded. Tonsil size 1 is where the tonsils are within the pillars, anterior and posterior pillars. Size 2 is when it is encroaching up to the pillars. Tonsil size 3 or grade 3 is when they have crossed the midline, crossed the pillars but not up to the midline, and 4 is like kissing tonsils. So based on this, they have given a score to each size, and finally the BMI, and it has been graded into 5 categories in it. Grade 0 is less than 20, 1 is 20 to 25, and similarly 2 is 25 to 30. Grade 3 is 30 to 40, and grade 4 is more than 40 kilogram per meter square. Based on this, we have come to a classification called a Friedman staging system. So with all our patients who come for assessment, we make a kind of staging system, which is more relevant for from the surgical point of view. So patient stage 1 is where the Friedman palate position is very low with a very big tonsils. So these are the patients who are surgically very good patients. They have got a very high surgical success rate. Stage 2 has got a very moderate surgical success rate where the tonsils are small and the FPP is also small, or the tonsils are very big and the Friedman palate position is also very high. Stage 3 and stage 4 are the patients whom we will not like to operate with the Friedman staging system. And this is basically done keeping in mind about the UPPP, and the surgical success rate was very high with the stage 1 and 2 and very poor with the stage 3. So based on the Friedman staging system, we give a score. We call it as an OSA score. So FTP from 1 to 4, BMI from 1 to 4, and tonsil size from 1 to 4. We give a score to each point, and we see if the score is less than equal to 4, then chances of having an AHI is less than 20, and it has got a very high negative predictive value of 68%. Similarly, the score is more than 8, and the chances of having an AHI more than 20, and it has got a very positive value of almost 90%. So these are the best predictors of severity of OSA combination, keeping in mind that the 3 parameters. and it also has some predictors for the surgical success. And it also helps to guide about palate versus tongue surgeries. This is the Friedman staging. The whole advantage of Friedman staging is it has got a very low cost. We can know about the success, but the biggest disadvantage with this is it is merely a theoretical assessment and not a dynamic assessment of sleeping patients. So for the dynamic assessment, we need to do either a drug-induced sleep endoscopy or dynamic MRI. But nevertheless, we will have some idea about the patient's anatomical knowledge based on the FPP grading. Finally, we have to look for the hypopharynx, and the best way to look for is by doing a laryngoscopy. We have to make a note about the base of tongue and the lingual tonsils. Look for the epiglottis, whether it is floppy or not, whether there is any epiglottic cyst or not, where there is an interarytenoid hipping of mucosa. Make a note about the arytenoids and AE folds, and also about the larynx. Sometimes we ask the patient also to do a Muller's maneuver, but this is not very practical in the OPD because we have to put a flexible endoscope inside the nose, and we ask the patient to close the nose and mouth and do the reverse of Valsalva. So they have to take a forceful inspiration, keeping the nose and mouth closed, and we see for the areas which are getting collapsed. This is controversial, and no studies have been able to associate the maneuver as a tool to select the patients who are likely to succeed with the surgery. So summarize, multi-level anatomical obstruction is often present in snoring and OSA, and this is a multidisciplinary subject, and so detailed anatomical knowledge should be noted by the attending physician or the surgeon. As the nose is the first anatomical boundary of the upper airway, nasal obstruction may contribute to SDB. A thorough clinical examinations in suspected OSA patients gives us the insight about the static obstructions. The FPP and Friedman staging systems helps us to know about the valuable predictor for the success of U-P, and it has some information regarding what we are going to get during surgeries. ENT endoscopy is mandatory and to rule out any static obstructions. Examination of the jaw and malocclusions can give valuable insight and should not be overlooked. And for dynamic assessment, we ultimately rely much on DIAS or dynamic MRI. In our patients, just to summarize, the patient was 40-year-old female. She had a history of snoring, EDS, tiredness, witness apneas. She had an uncontrolled hypertension. BMI was 30. The stop bang was 5. The Epworth sleepiness scale was 10. There was a gross septal deviation, and apart from that, nothing much was seen in the nose and nasopharynx. The Friedman position was 2. The Friedman staging was 2. That means the tonsil was also not very high, and the BMI was low, and the OSA score was 6. So based on this, we decided the patient should undergo a level 1 polysomnography, and the patient was referred for a PhD to know about the sleep study. So with this, I will end my talk. Thank you so much. And I think the second part would be about the sleep study and its implication by the next speaker. Thank you.
Thank you very much. Thank you very much, Dr. Agarwal, for nicely briefing the history and clinical examinations, particularly the upper airways. Now I ask Dr. Saurav Das, he's a psychiatrist. He is an MD, DNB, consultant psychiatrist, and addiction medicine and sleep medicine specialist. He has international certification on addiction medicine and sleep medicine. He has more than 20 international and national publications in his field. He has his own state-of-the-art sleep lab, and that's name is Somnos Sleep Clinic. Okay, and I would request Dr. Saurav Das to go for the investigation, polysomnography, in particular, to present his presentation. Thank you. Please.
Hello. Good evening, everybody. Thank you, DJ Roy sir, for introducing me. I would like to thank Dr. P.S. Bhattacharya sir for inviting me on this August platform. So my part is the second part. Like I'll be discussing about the PhD scoring and interpretation, and just general notes to the audience that this entire module has been made by keeping in mind that we have to take that particular case that we all will be discussing as the anchor. While doing that, we have to discuss about all the other variations or possibilities that could have happened in that particular patient while evaluation and management of a obstructive sleep apnea patient. So once a patient has been referred for polysomnography, we have to think that what type of polysomnography should we do to that particular patient, because there are various types of polysomnography. Broadly we can divide them to like at-home studies and in-lab studies. However, a more detailed classification system is available by which we divide polysomnography types into 4 types: level 4, level 3, level 2, and level 1, with descending order of sophistication. Now, coming to the coming to a bit details about how these systems differ. Now we can see here that the type 4 study has only 1 or 2 parameters under observation, that is the airflow and oximetry, or sometimes they can have either airflow or oximetry. This is almost always used as a screening tool to detect if the person has any kind of OSA, or if the person needs to be sent to a sleep lab or for detailed sleep testing evaluation. Now, type 3 study is a little bit more sophisticated than type 4 study. It also includes an ECG or heart rate, or and also it also has some belts to put on the chest for or the abdomen, or both sometimes, to measure the thoraco-abdominal movement. So basically, these type 4 and type 3 studies can be done at home without any medical supervision. The patient can himself wire himself up with the whatever device he or she is being given, and they are used to monitor the cardiorespiratory parameters while the patient is sleeping. Now, level 1 and level 2 studies differ from them is that because they contain all these things. In addition, they also have certain neurological channels, starting with the EEG or electroencephalogram, EOG electroculogram, and EMG electromyogram. So once these neurological channels are added to this cardiorespiratory channel, the study becomes a higher quality study than the level 3 or level 4. It becomes either level 1 and level 2. Now, level 1 and level 2 studies have the similar kind of configuration. Only difference is that for level 1 study, you need to have a trained sleep technician who will be continuously supervising the entire study night. Like, he will be monitoring all the graphs that is showing on the computer screen, and if some of the wires get loose, or the nasal cannula gets loose, and he has to tighten them up, so that you get much more reliable and good quality of data. And level 2 is that you just have all these channels, you fix it, may hook up the patient, like make him or her go to sleep, and then forget about it. In the morning you come and take the channels off. So these are the level 1 and level 2 studies basically. Now, of course, there are certain benefits of in-lab polysomnography compared to portable sleep testing, because in-lab testing, they are much more elaborate and authentic. They have a large number of channels to observe a lot of parameters while the patient is sleeping, usually in the range of 55 to 60. They have the ability to diagnose full spectrum of sleep disorders. They can take in a large data volume with unlimited runtime, and often they are associated with video recording, which is immensely helpful for certain cases. On the other hand, portable sleep testing is also relevant in certain cases. Particularly, they are helpful for infirm or immobile patients who cannot be brought to the sleep lab. They can be done in ICU settings sometimes, and they are obviously less expensive, and the patient can also sleep in their familiar home environment. Now, after the sleep polysomnography, we have decided which type of polysomnography we want to do based on the particular patient. Now comes the part of the scoring. Like, for example, like the scoring can be done by automatic method, using just by clicking a couple of buttons on the software that is provided with the device, or it can be scored manually. And this manual scoring is ASM recommended. It is considered as a gold standard of PhD scoring, because PhD software that are used for scoring can interpret EEG data only with 40 to 50% accuracy, and hence, if the sleep-wake stages are not appropriately identified, it becomes very difficult for the generation of a correct, authentic report. So these are the two different ways of testing. Now let's see how these devices look. So we can see here that this model A, this is a type 4 device. It has this a cannula for putting in the nose while the patient is sleeping, and it detects the airflow. Now this B1 and B2, they are level 3 devices. You can see these are a bit larger and more sophisticated compared to this device A, and it is though it is a little bit sophisticated, it is much less intrusive for that patient. And we can see here that this nasal cannula is there. We can measure the thoraco-abdominal movement here. We can measure the oximetry, and we can measure the heart rate, or like pulse rate rather here. So this gets the cardiorespiratory data for us. Now this, like these two are like the level 1 devices. We can see here that this patient is sleeping, and there is this box, this is called the head box. It has lots of, provision for putting in a lot of wires, and these wires come out and get attached to the patient's body through various kind of sticky glue. And this is the main unit which contains the processor and which measures all the whatever data is there. Now this device itself is again connected to a computer which can be monitored continuously and intervened by the sleep technician. Now, as we were discussing, that for any patient, when we are referring a patient for polysomnography, we need to think on a lot of factors, including cost, including availability, and including the patient's clinical need. Now, for example, in this patient had been referred for level 1 study directly because the lady had a history of uncontrolled hypertension, and since there is some medical comorbidity, it is always preferable to go for a level 1 study. Now, for level 3 study, which is done at home in patient's home, we can get the various parameters like apnea hypopnea index and cardiorespiratory parameters. Now they usually understate the patient's severity. There are two reasons for that. The first reason is that since they do not have the EEG channel, they do not know exactly when the patient is awake or when the patient is asleep. And excuse me, there is some noise in the background. Can someone mute the mic, please? Yeah. Thank you. Okay, so as I was saying, in the level 3 study or at the portable sleep study, there is some under diagnosis of the severity of the obstructive sleep apnea, because since the EEG channels are missing, the machine cannot detect when the person is actually asleep, when the person is actually awake, and when the person is awake in the night time, they will not have any OSA or AHI. So the HI value, that is HI value, is basically the index of apnea plus hypopnea, that is the amount of time the person is not breathing or partially breathing divided by the total number of total sleep time. That is called AHI, which is a very important index. I'll come to it in the part of my presentation. And that thing is not there. And secondly, in this classificatory system, there are this detection of hypopnea. For detection of hypopnea, you need to have a partial closure of the airway along with an aerosol. That is one of the mechanisms by which you detect the hypopnea. Now, since EEG is not there, the aerosols cannot be detected. Therefore, those hypopneas are not classified in a level 3 device. So, American Association of Sleep Medicine has given certain indications of portable sleep monitoring. I will not read up all these things, but grossly, if there are any significant comorbid medical conditions, they should be referred for level 1. If the person is suspected of having some other sleep disorders like central sleep apnea, PLMD, insomnia, parasomnia, etc., the person has to be referred for the level 1 sleep disorder. And for general screening of asymptomatic population, also level 1 is more recommended. Now, portable sleep monitoring is basically just like chest X-ray is to CT scan for detection of lung cancer, and fasting glucose is to oral glucose challenge test in terms of diabetes. So that is the comparison of home sleep testing versus in-lab sleep testing. Here we can see this is my lab. This is the lab of Dr. Agarwal. This is the lab of Dr. Datta and Dr. Haldar. So this is my idea of putting in these slides of showing all these labs is basically that we can see that these labs look nothing like hospital beds. They rather look like a bedroom or like the room where we go and stay in a hotel. So basically they are designed in such a way to make the patient feel comfortable to come into the lab and fall asleep rather than generate some kind of anxiety as if the person is sleeping in a hospital bed. So how does it look like? This is just a schematic representation. We can see that there is a person who is sleeping. These electrodes monitor the brain activity, the EEG. This nasal cannula monitor the airflow. There is this microphone recording this snoring. These belt monitors the breathing movement of the chest and the abdomen. And these electrodes monitor the muscle movements or leg EMG. Sometimes you can also give it on hands also for certain set of patients, or they can be given on the masseter also to measure the jaw movement or movement of the jaw particularly. So this is how it looks like schematically. And now I'll come to the first part of sleep scoring, that is the neurological scoring, mostly the EEG basically. So first, this is how a standard graph looks like. Like when a person falls asleep, the person is say awake. Then first they come into a stage 1 of sleep, then stage 2, and then stage 3. Now stage 3 and 4 had been clubbed together in the recent times, and stage 1, 2, and stage 3, and then again they go back to 3, 2, 1. They again come down to 1, 2, 3, like that. This kind of thing happens. Now, one thing important that has to be noted is that the deeper stages of the sleep, like stage 3 and 4, is more common in the early part of the sleep, while the REM sleep, that is the type of sleep when we actually dream and you can recollect those dreams, those REM part is more common in the later half of the night. So again, I would like to mention one small thing here, that there are certain cases where we are forced to, or where we do this split night diagnosis or split night polysomnography. They have an inherent problem, is that we diagnose the first part of the night, and based upon that we titrate in the second half of the night. So what is missing is that since we do not get the REM data, and why the REM data is important, that comes in the retrospective presentation, we often miss out on a lot of information on that particular patient when we do split night polysomnography. Okay, so these are the EEG waves, and we can see how they are looking. This is the awake wave. They are basically called beta waves, having a frequency of 13 to 30 hertz. Stage 1 is like this. Stage 1 looks like this. They are combined, and they consist of mostly theta waves with 4 to 8 hertz. Stage 2 is also contains theta waves, but there are certain things called K complexes and sleep spindles. You can see here. K complexes are basically biphasic waves having duration of greater than 0.5 seconds, and sleep spindles are a bit they have this frequency of 12 to 14 hertz and are interspersed in the stage 2. These two, if present, we classify the sleep staging as stage 2. Now stage 3, they consist of mostly delta waves, which have a frequency of 0.5 to 4 hertz. Some say it is 0.5 to 3 hertz. They are basically, they look like mountain peaks, and stage 3 and 4 are clubbed together now. And REM is basically a very polymorphic kind of wave pattern, very similar to that in the stage 1. But the difference is that the chin tone through which we get through EMG is very low in the REM, and we of course we always get often get various like eye movement that will come and show in my graphs. Okay, so this is how they actually look like in a PSG graph. You can see that the entire night sleep is broken down into small epochs of 30 seconds each while doing the scoring. We can see the scoring here. We can see the time of the study is being done here. And we can see in this video the patient is actually sleeping. This is a different patient, not our index patient. The patient is sleeping. And these are the EEG channels, these are the EOG channels, these are the EMG channels, these are the ECG bits, as you can see. These are the leg EMG channels. This is the microphone to monitor the snoring. This is the airflow. There are two types of airflow measurement, and these are the thorax and abdominal belt. This is an oxygen level oximetry that is being monitored continuously. This is the plethysmography, that data can be obtained from the oximeter channel itself. And of course, there are the body position sensors also there. Okay, so we can see that this is the wake stage, because there is lots of alpha waves that we can see, which is frequency of 8 to 13 hertz, and if this is present, these kind of waves are present for more than 50% of the slide, we consider it as a stage wave. Now this is when the patient has actually getting into sleep. This is stage 1, where we can see that these alpha waves are decreased to frequency to the duration less than 50% of the entire slide. And there are the slow rolling eye movement. This is the EOG, and they monitor the eye movement. You can see there are the slow rolling movements is present, as well as the chin tone reduces compared to these awake stage. You can see the chin tone here and the chin tone here. There is a difference in the chin tone. So this is how we start classifying the patient as stage 1 of sleep. Now again, this is a graph which shows the stage 2 sleep. You can see that this is a K complex here. You can see this is a biphasic wave having a duration more than 0.5 seconds. You can see the sleep spindles here. In the night, and the others you can see. Yeah, so now this is stage 3, where we can see on first glimpse we can see that there are like this graphs, EEG graphs look like mountains basically. These are all delta waves, you can see here very well. This is where the person is sleeping in deep sleep, stage 3. And this is a very interesting slide. Please note that this is how a person gets into a REM sleep. We can see that this is where the person gets into a REM sleep. Why? Because you can see these sharp eye movements. Compare it to the stage 1 slow rolling eye movements. Here, these slow rolling movements. This is very different. With these are sharp, rapid eye movements. This is present, and also the polymorphic wave is present. And most importantly, we can look at the chin tone. Now, look at this chin tone here, and look at the chin tone here. We can see this sharp demarcation that the person has got into this REM stage. Now, again, this is another REM stage where you can see these sharp eye movements. And this is another slide. This epoch is actually compressed into a 2 minutes slide. You can see there 2 minutes. And these, I have put it here to show the leg EMG channel. How do they look like? These are EMG channels. You can see leg. You can see there are bursts of leg activity. Like here, this is called limb movements. And since this actually is a case of periodic limb movement because they have been, there are a cluster of 4 or more between 5 to 90 seconds duration. This we can see as snoring. Okay, so now let's come to the cardiopulmonary part of the PhD scoring. Okay, so the cardinal features which we need to assess is airflow and the respiratory movement. We can see that this is a graphical or schematic representation of the airflow. We can see that how breathing is happening, and this is respiratory movement. So we can see that the airflow coming out and coming in through the nose is parallel to the movement of the chest or the abdomen. You can see here this is normal. Now if when we get that there is loss of breath, there is no air is coming out through the channels through the nose, and there is no movement of the chest or abdomen, then we get a flat here, and we can see that at least more than 2 such breathing episodes are missing. So this is what we call as central apnea. Now, on the other hand, if there is airflow is missing, but the respiratory movement is continuing, this is what we call as obstructive apnea. Now, of course, there is something called obstructive hypopnea, which I have not shown here, which is basically airflow is not completely absent. It is present, but it is decreased. The peak is diminished by 30% or more compared to the average peak height, peak amplitude. And mixed apnea is something where we get this airflow is missing, the respiratory movement is missing in the initial part of the airflow movement missing, and then later in the later part the respiratory movement starts again. So this is the mixed apnea. Okay, so let's have a quick look how this look in a real life patient. So this is our index patient, as we can see here. The lady was showing this hypopnea. We can see that this decreased compared the amplitude of the waves here and to that of this here. So you can see that there is reduction. Along with that, there is desaturation. Like the oxygen level was 92 in the beginning, and then it got down to 84. So this is the SpO2. This measures the oxygen, and this is the airflow, and these are the chest and abdominal movement. You can see the movement is happening. So this is obstructive hypopnea. So now we can see here in this graph, this lady is showing us obstructive apnea proper, because we can see that this is a flat. This airflow is actually flat, but the chest and abdomen movement is continuing. At the same time, oxygen level, we can see that from 88 it has gone down to 77. So this is what is happening in that particular patient. That we can with this we can find the features of obstructive sleep apnea in this particular patient. Now this is what the central apnea looks like. We can see that there is a flattening of the nasal grafts, and similarly flattening of the chest and abdominal belts also. And there is this is the central apnea is happening. Now another thing we have to monitor, see here that this is REM sleep. As you can see, these are the sharp eye movements in the graph is showing that this is the REM part that we're scoring right now. And we can see that in this particular lady, in the REM sleep, the oxygen level has gone from 77 to 46. So this is much lower compared to what we are getting in the initial part, which was in the, like you can see here, the non-REM sleep. So this is a striking important finding, which was when we looked into the study in details, we found that when the lady was getting into REM sleep, the oxygen level was desaturating in a more severe manner. This is a mixed apnea. We can see that this is more or less flat. There is flattening of the chest and abdomen curve in the beginning, and then the graph picks up. Again, we can see that the oxygen level has gone down to quite low, 51%, 56%, and again this is in the REM sleep. So just a point to note that in this particular patient, we can see that the desaturation was quite higher, and the duration of the apnea was also quite longer in the REM sleep compared to the non-REM part. You can see here the apnea is shorter in duration and the longer in during the REM sleep. So this lady had something to do with the REM sleep. Let's see how to understand the report. So many of us are familiar with the polysomnography report. It has lots of gibberish being filled up. We can see this, that, and that. It is very confusing, and sometimes it can be overwhelming, particularly to those who are new in the subject. And we try to search what is making sense, what is making sense. We find out, okay, we have got index or total this thing, and this we have got this AHI. So the person is having an AHI of 47.4, so we can simply ask the person to get a Cpap, and our job is done. But unfortunately, in sleep medicine, there's a lot of more things to consider. Ideally, what we have to look at when trying to read a report is we have to start with the total time in bed, which will say that which will denote how much time the person actually spent in the bed in the lab, and the total sleep time, and among that total time period, how much time the person has actually slept, because this total sleep time is the denominator of all the data that we'll get in the in the further part of the study. We can get the sleep efficiency. In this case, you can say 74.4. We also have to look at sleep onset, like how much time the patient took to fall asleep after lying down on the bed. In this case, it is 4 minutes. This is a bit shorter on the shorter side. Usually, they take around 8 to 15 minutes time. Also, we need to look at the wake after sleep onset, which is here it is quite high, because after sleeping the person woke up multiple times with either microarousals or full-blown arousals. We also need to look at the staging as to like what kind of sleep the person was having, like the M1 sleep, into sleep, MC sleep, and what were the percentages and total deviations. So that is very important data. We can see here the person was having quite less amount of REM sleep than is recommended, than is usually needed, which is around 20 to 25%. And on the other side, the person was having increased slow wave sleep, which is again usually happens around 20 to 25%. We also have to look at the maximum, the mean duration of these obstructive events, or the events, whatever central events also. We have to look at the, in this case it was 18.3 seconds. We have to look at the maximum duration, not only the mean duration, we have to look at the maximum duration of these events. Here we can see that 77.5 seconds, which is more than a minute, the person was actually not breathing. And and also we have to look at the REM versus NREM count, like how many apneas happened in the REM sleep and how many happened in the non-REM sleep. We can see that in non-REM sleep it was more, in the REM sleep it was less, but since the REM period was very small, we have to consider the index also. Like you can see that there is something called this REM index and there is something called the non-REM index. Like the number of obstructive apneas present in the REM part was much higher than that in the non-REM part. You can see here the 34.6 is to 10.8. Similarly, the hypopneas are also more prominent in the REM sleep than in the non-REM sleep. And we also have to look at the respiratory events based on the body position, because whether the person is supine or prone or left or upright or right. And we can see that what is the like AHI or RDI in that particular patient. Because often we see that there are many patients who have more obstructive events while the person is lying supine. So in that case, we can always try some little bit of positional therapy, which actually helps in the patients. So we also have to look at the number of arousals per unit time, per hour of sleep time, total sleep time. You can see that here it is quite higher arousal index. We also need to look at the periodic movement sequences and the PLMS arousals. So after this, we also have to look at the cardiorespiratory parameters. We need to see the total number of oxygen desaturations for that patient. We need to see like the mean oxygen saturation while the person is awake, while the person is having non-REM sleep and the person is having REM sleep. We can see for this patient the REM mean SpO2 is much lower than the non-REM SpO2, and that has been explained because we earlier saw that the amount of desaturation was quite higher, and the apneic scales are much longer in the REM sleep, while the person rather compared to that in the non-REM sleep for this particular person. We also need to look at the amount of time spent having a saturation of less than 90% while the person is sleeping. And we also need to look at the minimum SpO2 that was reached for this particular patient. So we also have to look at the average heart rate during sleep. We also need to look at the lowest and the highest heart rate that is present during the sleep. And last but not least, we need to have a quick look at this particular graph, which is called as Hypnogram, which is present in all the sleep study reports. So this graph summarizes all the data that we have seen till now. It has these Eeg classification, this oxygen levels. You can see the dip here, and just beneath the REM there is this dip. Then there is REM, there is this dip. This is falling lower. There is heart rate, arousal, obstructive apnea, mixed apnea. And you can see again the obstructive apnea concentrated in the REM part more, again in the REM part more compared to the rest of the study. Hypopnea, similarly, the frequency is higher, and the body position you can see here that how the position is changing. So this gives us an idea of as to what is happening in the person's sleep. Now, I would also, apart from this particular patient, this is what we had found in this patient. I would also like to have spend a few minutes discussing that when we are seeing a report, this REM dependent apneas can vary in different, come in all shapes and sizes. For example, you can see that in this particular patient, there is this is another person, Mr. A, who is 56 years old, having BMI 27. This person's in sleep time, this person's apnea hypopnea index is 57. That is, and the person's REM index again is 59, non-REM index is 55.8. So we can see there's not much difference in the REM is to non-REM index. But if you look more closely, we'll see that the number of apneas is much higher in the REM sleep compared to the hypopneas in the REM sleep. And this increased apnea have led to an increased desaturation during the REM sleep than in the non-REM sleep. This is one person. Another case is Mr. B, who is 29 years old, having a BMI of 29. And we can see here that this particular person is having a very moderate kind of OSA with AHI 23.1. But the person is having significantly higher obstructive events during REM sleep compared to non-REM sleep, and also hypopnea in the REM sleep compared to non-REM sleep. Thereby, we can see that the REM index is 80 compared to only nearly 20, like 4 times higher number of obstructive events happened in the REM sleep while the person having non-REM sleep. Now there is this Mr. C, who is 68 years old, having BMI 27. We can see that the person's apnea hypopnea index is 43.7. And however, there is not much difference in the REM and non-REM part, but the REM oxygen desaturation is much lower compared to the non-REM desaturation. So not only the index, but also we have to look at the duration. This particular patient has had longer duration obstructive events while the person was in the REM sleep, and thereby, though the index remained similar, the desaturation was much lower in the REM part. Similarly, there is another patient, 68-year-old Mr. G, having BMI 37. This particular patient had AHI of 116 overall, with more or less similar index during the REM and non-REM part, but the person was having a very significantly low oxygen levels during REM sleep compared to non-REM sleep. Now, this was because the person was having central apneic events and mixed apneic events much higher in the REM sleep than the non-REM sleep. Again, there are other cases like these where we see that a very mild, like moderate, just on the borderline of mild to moderate OSA cases, we can see here that this person is having the obstructive events mostly in the REM part compared to the non-REM part. Again, the similar finding with these female 40 years old having this 15 REM index compared to non-REM index. Now, these patients, if you follow up over time without any intervention, we will see that they will gradually develop into a full-fledged OSA. And this is often, in many cases, the REM sleep dependent OSA is the beginning of this patient's journey into the OSA, and gradually the OSA develops in other parts of the sleep also. Now coming to, let's spend just a couple of slides in talking about what is REM-related obstructive sleep apnea. And there is always this doubt as to whether to treat or not to treat this particular patient. It has been seen that REM-related OSA occurs more commonly in younger individuals, in women, in children, and in patients with mild to moderate OSA, as we are seeing in the last few graphs. And also they tend to have an overall low AHI by virtue of the disproportionately lower percentage of REM sleep as a function of total sleep duration. This again we had seen in the previous graph that I have mentioned. These are all real life cases, I must tell you. Now it has been well established that compared to non-REM sleep, REM sleep is associated with greater sympathetic activity and cardiovascular instability in healthy human subjects. And patients with OSA, the hemodynamic and sympathetic changes REM sleep cause a surge in patients with cardiovascular disease. So indeed, obstructive apneas and hypopneas during REM sleep lead to greater degrees of hypoxemia. So this is a very famous article in the Journal of Clinical Sleep Medicine, and they've seen that they mentioned that it remains a clinical conundrum whether asymptomatic or minimally symptomatic patient with REM-related OSA who typically have an overall low severity of the disease as measured by AHI should be treated, or whether they should derive any benefit from Cpap therapy. Now, to shed light on these things, a recent retrospective observational study was done where the authors evaluated a cohort of patients with REM-related OSA and compared them to non-stage specific OSA, and they found that symptomatic patients with REM predominant but not REM exclusive OSA benefited equally from Cpap therapy compared to patients with non-stage specific OSA as it relates to sleepiness, fatigue, and quality of life. Similarly, another important study done in 2016, they found that REM OSA is independently associated with prevalent and incident hypertension, non-dipping of nocturnal blood pressure, increased insulin resistance, and impairment of human spatial navigational memory. So with these, I would like to finish my presentation, but one pulse of wisdom which I personally feel is that we as sleep physicians, we need to have a broader frame of mind, and we have to understand that sleep medicine is not only about obstructive sleep apnea, and even more importantly, obstructive sleep apnea is not only about AHI. There's a whole sea of things out there. We just need to look for them. Thank you so much for your patient listening. Thank you.
Thank you, Dr. Das. And we must keep time because we are exceeding time. Next speaker would be Dr. Arup Haldar. He will be speaking. Dr. Arup Haldar. Yes. He is DCH MD consultant pulmonologist. He is associated with Institute of Sleep Sciences. He also performed as a national and international speaker. He also has several publications in index journals. And so, Dr. Arup Halder, please just speak about the treatment part of the obstructive sleep apnea. We must try to keep ourselves in time. We're running short of time.
Hello.
Yes, Arup. Please.
I am audible, I think.
Yes, very much.
Yeah. So my job is to treat this patient. So before going to that, just first a brief recapitulation of the history. So it's a 40 years old female of BMI 30, stop bang of 5, and EPSS of 10, Malampati of 4. Her AHI was 47, desaturation index was 50, and lowest saturation was 73%. There was distortion of sleep architecture, and it was a predominantly REM dominant OSA with the AHI of 106.2 and NRM AHI was 39.9. And she had a history of drug-resistant hypertension for 3 years. She was euthyroid and having no other comorbidities except the obesity. So how we proceed in diagnosis or how we proceed in the treatment of such patients? First, you have to confirm the diagnosis. So we have confirmed the diagnosis with polysomnography. She is having severe OSA and predominantly REM dominant OSA. We have to look at the titration report that has not been done still, and we have to do the titration. We have to look for any other sleep disorder. She is not having any other sleep disorder like parasomnias or insomnias. We have to look for the comorbidities. She is having a drug-resistant hypertension. And we have to formulate a treatment protocol based on these parameters, and we have to arrange for the follow-up. So what are the treatment options available for OSA? So we have positive airway pressure therapy, we have oral appliances, we have surgery, and we have conservative therapy like weight loss, positional therapy, etc. So PAP therapy or continuous positive airway pressure therapy is considered to be the gold standard in the treatment of OSA, and this was invented by Colin Sullivan in early 1980s. And it exerts its action by a pneumatic splint that maintains the patency of the upper airway in a dose-dependent fashion. And it acts as a treatment, not as a cure for this syndrome. So it exerts the airway dimension in the lateral walls. So you can see this is before CPAP and this is after CPAP. The airway lateral dimension has increased. So we have two kind of PAP devices, as we all know. We have CPAP or continuous positive airway pressure devices, which exerts a single fixed pressure throughout the night. Suppose we have set the pressure at 10 centimeter H2O, it will keep the pressure 10 centimeter H2O throughout the night, irrespective of the respiratory events or whether the patient is awake or asleep. And we have APAP or auto pressure PAP devices, which has a varying pressure and that adjusts automatically in response to the changes of airway patency. So we start the minimum pressure of 4 centimeter H2O, and the maximum pressure can be reached at 20 centimeter H2O, and the pressure will vary automatically depending on the some parameters like the airflow. So these devices can monitor the airflow by the motor speed, or it can depict the flattening of the airflow. It can detect the snoring by the airway vibration, and the new machines have also fitted with airway force oscillation technique, which can measure the airway impedance, and it can change pressure according to that. The classical indication of CPAP in OSA previously was in treatment of moderate to severe OSA and with mild OSA if associated with symptoms or underlying cardiovascular disorder. But there has been some changes into this indication in 2019, and I will discuss about that. So before prescribing the Cpap, we have to do a titration. So what is the titration? We have to find a pressure which will abolish all these flow limitations in the airway during sleep. The gold standard is always a full night manual titration, but we can go for a split night titration if the initial AHI is more than 40 per hour for initial 2 hours, and we have 3 hours for titration night. Or we can go for APAP titration, and there is also APAP split night titration, but that is still not recommended, and this is purely experimental. But in our own study, we have shown that APAP split night titration can also achieve an optimal titration within a very short amount of time, but this is purely experimental, and this is not recommended by recent AASM or American Academy of Sleep Medicine guideline. So in 2019, there has been formation of a task force by American Academy of Sleep Medicine, and they included few specialists, board certified specialists, who formulated a treatment protocol for positive airway pressure therapy and titration according to the changing evidences what has been accumulated till now. The previous recommendation was in 2006, 7, and 8, and that has gone radical change in the recent guideline. So based on the evidences, they have formulated either strong recommendation or conditional recommendation. Strong recommendations are, that means we should all follow these recommendations, and conditional recommendation means we can follow this recommendation, but we can apply our own knowledge or the patient's choices, or we can change it according to the patient needs. So they have formulated actually 9 recommendations, and this is a flow chart. You can go through it. You can download it from ASM website. Their first recommendation was, we recommended that clinicians use positive airway pressure compared to no therapy to treat OSA in adult with excessive daytime sleepiness, and it is a strong recommendation. So that means if the patient is having OSA with excessive sleepiness, he or she should be prescribed positive airway pressure, and he or she should not be left without any therapy. The recommendation 2 was, we suggest that clinicians use positive airway pressure compared to no therapy to treat OSA in adults with impaired sleep-related quality of life, and this is a conditional recommendation. So that means if the patient has a decreased sleep-related quality of life, that means he is having snoring or having some daytime sleepiness, or along with the bed partner is complaining of sleep fragmentation due to the snoring of the spouse. So all these are actually indications to recommend Cpap or APAP for these patients, but this is a conditional. The evidence are weaker than the stronger recommendation. And recommendation 3 is that we suggest that clinicians use positive airway pressure compared to no therapy to treat OSA in adults with comorbid hypertension. So it's a conditional recommendations. So by these recommendations, we can conclude that patients should be prescribed a Cpap when he is having excessive daytime sleepiness, or he is having a decreased quality of life due to the snoring, or he is having an hypertension. The first recommendation is strong, and the other recommendations are conditional. So we have moved away from this mild, moderate OSA and Cpap prescription and all these things, and this is now much more specific. The recommendation 4 was, we recommend a positive airway pressure therapy be initiated using either APAP at home or in-lab PAP titration in adults with OSA and no significant comorbidities. That means APAP titration has also been given similar importance like the in-lab Cpap titration, and this is a strong recommendation now. The recommendation 5 was, we recommend that clinicians use either APAP or Cpap for ongoing treatment of OSA in adults, and this is a strong recommendation. So previous reservation about APAP has much been removed by the recent recommendation, and we can use either APAP or Cpap for treatment of OSA. But we have to remember that their studies has not included patients with congestive heart failure, having COPD, or having central sleep apnea, or those patients who are being treated with surgery, or those patients having obesity, hyperventilation syndrome. So these are actually these patients should actually be excluded, and there is actually no recommendation for them what should be used, either CPAP or APAP, for or against. Recommendation 6 was, we suggest that clinicians use APAP or CPAP over BPAP in the routine treatment in adult patients. So they have preferred a CPAP or APAP over BPAP, but BPAP has certain indication in certain subgroups, and these are conditional recommendation. The recommendations 7, 8, 9 are all related to the educational interventions required before initiating PAP therapy and the troubleshooting interventions to be given during the initial period of PAP therapy in adults with OSA. So we now incorporate a cognitive behavioral therapy before prescribing CPAP or APAP to any patients, and without it, often the compliance becomes poor. So first we have to do a titration for this patient, and we have to see the titration report, whether it was an adequate titration or inadequate titration. So titration is based on adequacy of titration is based on several factors. Like for optimal titration, we have to reduce the respiratory disturbance index or AHI to less than 5. The saturation should be more than 90%, and the supine REM sleep should be uninterrupted by spontaneous arousals and awakening. So if these all are achieved, so we call it an optimal titration. And we have certain protocols for APAP titration also. So how we do the APAP titration? We provide the APAP machine to the patient with an SD card inserted, and we review the report at day 3, day 7, and day 30. So this protocol may vary from institution to institution, but this is a usual recommendation or usual practice we follow in a day-to-day practice. Day 3 is for those patients who are satisfied after day 3, and if they're not satisfied with the use of APAP titration, we extend the duration to day 7 and maximum to day 30 in our institution. And we observe the following things. We observe first the patient satisfaction of the required amount of days, whether the patient can sleep with the device or not, or how he reports his symptoms in the early morning. What was the AHI? The machine can measure the AHI. What was the AHI of the patient? What amount of pressure that was required to abolish apnea or hypopnea? What was the 90% pressure, or what was the 95 percentile pressure? So we watch that, and we watch for any leak or mask application. All these reports are given by the APAP machine, and this is a typical report of this typical compliance report. You can see this is a 158 days report, and patient has not slept, has not used the machine for 22 days, and you can see the AHI, residual AHI was 5.7, and the 90% pressure was around 8.9 centimeter H2O. So you can download all these reports from the APAP machine. Now, before prescribing APAP or CPAP, we have to do a patient education very sincerely and meticulously. Otherwise, patient will be non-compliant. We have to give them idea about what is called sleep hygiene. We have to advise them about the lifestyle modification. We have to show them what are the benefits of CPAP therapy. We have to show them how the mask is fitted properly, and what to do during the troubleshooting period, like the dry mouth, nasal dryness, if there is excessive pressure or skin problems, how to handle these things, and how to maintain the machine. And we arrange for follow-up at 1 month, 3 months, and 6 months, and thereafter 6 monthly. We observe the clinical benefit. We review the SD card from time to time for the compliance of CPAP. We answer any queries related to sleep or CPAP, and we continue patient education and look for any failure of CPAP. Because CPAP is often becomes intolerant or is not, they do not use the CPAP very regularly. So we have a definition of compliance. So definition of compliance means use of CPAP greater than 4 hours per night for 70% of the observed night. Though the subjective compliance often varies from 65 to 90%, but the objective compliance measures are often less than 50%. And a good cognitive behavioral therapy or continuous motivation to the patient can often increase the compliance of CPAP or APAP. But a pattern of CPAP compliance can usually be determined within the first few hours or few days and certainly by the first 3 months. So this time is very crucial. We have to stick to the, we have to motivate the patient during first few months, and if he or she uses this machine for first few months, is going to use for a long time. There are few suggested predictors of good compliance, like if the E4 sleepiness scale is more than 10, or if the AHI is more than 30, or good compliance in the first 3 months actually predict a good compliance in future. And the level of CPAP pressure has not been shown to be a predictor of CPAP use. There are some problems maybe associated with CPAP, like claustrophobia, nasal congestion, and poor mask fit leading to leaks and skin irritation. And we have certain measures. We can discuss this problem with the patient, and we can quite easily handle all these problems. And there are certain masks we have to be very meticulous about using the mask, because this is a mask which remains in touch with the patient, not the machine. So patient should be given free hand in choosing the mask. Usually we prefer the nasal mask or nasal pillows, but patients having other problems like COPD or all these things, we often prefer the full face masks. Apart from CPAP, we have other devices also to treat OSA, but these are sophisticated devices and they do not require in most of the patients. These are BPAP or auto BPAP or BPAP or adaptive servo ventilation or AVAPs, but a few subset of patients may require that, but it is beyond today's discussion. The present patient had a problem with the APAP, and he used to remove the mask during sleep, and we often see patient used to remove the mask during sleep because APAP achieve a very high pressure due to some leak. And as we all as the first speaker have shown, the patient has a DNS or deviated nasal septum. Often these patients have an initial intolerance to the pressure of the PAP devices. So we do not know whether this is a reason or not. Though the patient was partially tolerant to CPAP, he was not ready to use it because in most of the nights he used to remove the mask, and he remained symptomatic even after using the CPAP. So in that case, we call it a Cpap failure. So what is a Cpap failure? If there is persistent symptoms in spite of adequate compliance, or if the patient is intolerant to CPAP or BPAP even after the best effort, or a straightforward denial to use CPAP and wish for corrective surgery. In all this case, we call it a Cpap, though it's still this does not have a clear-cut definition. So in that cases, we refer this patient to ENT surgeons and sometimes to bariatric surgeons if they have a morbid obesity. And this index case was referred to Dr. Dipankar Datta, my next speaker, for further evaluation and management. So with that, I'm concluding. Thank you.
Thank you, Arup. Thank you. Very well spoken. I now request Dr. Dipankar Datta, the ENT surgeon, and to speak about the ENT management of obstructive sleep apnea. Dr. Dipankar Datta is MS consultant ENT and sleep apnea surgeon, represents India as presenter faculty in sleep disorder sessions, has more than 17 years of experience, runs his sleep disorder clinic in Bellevue Clinic and Institute of Sleep Science. So I invite again Dr. Dipankar Datta to have an overview of the ENT aspect of treatment of obstructive sleep apnea. Dr. Dipankar Datta. Dr. Dipankar Datta, it's not on the screen. Dr. Dipankar
Could you follow my screen, sir?
Yes, yes. Now
yeah.
You are visible. You are visible. Please.
Yeah.
Please keep the time.
Yeah, sure, sir. First of all, thank you very much, Dr. DJ Rai, sir, Chairman, sir, for the kind introduction. And thanks and congratulations to Dr. Parthasarathi Bhattacharya and his team, PULMOCON. And I am honored to be here again in this PULMOCON platform. Grateful to PSB for inviting me every year into this esteemed platform. My topic of discussion today is the fourth part, that is the role of surgery in Cpap non-compliant patients. When I am getting a patient from my physician colleagues after being diagnosed, after having given undergone the Cpap trial, the patient has probably refused Cpap trial. Now the patient, that particular lady, turned up to me. So Cpap vis-a-vis surgery, is it competitor to each other or it is complementary to each other? We have to keep it in mind that snoring and obstructive sleep apnea management, we have to judge this versus issue with each and everything as a pros and cons, and we have to compare the pro and con of both. And it's not a duel, not only because physicians are our friends, but it is a dual. It's a comparison between two available choices, each with advantages and limits. Cpap is the gold standard management for obstructive sleep apnea, accepted. But unfortunately, many patients experience Cpap therapy as intrusive, and the acceptance and long-term compliance of Cpap are, at best, moderate. A vast body of literature exists on long-term compliance of Cpap with rates ranging from even 29 to 83%, which is a huge range. Cpap failure has already been discussed by Dr. Arup Haldar, what is called as Cpap failure. And the main causes of failure are, number one, structural reasons. Number two, misdiagnosis and or coexistent sleepiness from other causes, claustrophobia, and anxiety and depression. How many people with moderate to severe OSA don't entertain even the possibility of using Cpap? We have no data, but Cpap purchase rate after PhD Cpap titration is approximately 50%. And we have to give insight why these rest 50% didn't even went for Cpap purchase. Claustrophobia resulting in low adherence, anxiety and depression resulting in low adherence, and predominant mouth breathing rather than nose breathing is another cause to low adherence of Cpap. And another determinant factors are machine cost, technical characteristics, and prescriber motivation. But can we ENT surgeons play some role here? Certainly, yes. What are the situations? Number one, multi-level sleep surgery for Cpap non-compliant patients. And number two, to eliminate structural blocks to improve Cpap compliance. Role of upper airway surgery is when PAP or oral appliances is declined or ineffective after at least 3 months trial of therapy, and most effective in patients who have OSA due to severe surgically correctable obstructive lesions of upper airway. Once upon a time, surgery for OSA was equivalent to UPPP, that is uvulopalato-pharyngoplasty. Is it a myth or reality? Let's see the evidence. UPPP failed, and UPPP failed because other anatomy obstructs. Is a benchmark publication during 1996 in Sleep, because there are plenty of other anatomy which we actually didn't assess that time. And previous concept of ENT surgical management for OSA, actually we ENT people didn't evaluate sleep in those days. Minimum importance we used to give for the obesity aspect, and we used to concentrate only on nose and palate. But our current ENT approach is we assess the upper airway, we assess the sleep pattern, and we assess the level of obstruction. So proper workup is the key. Severity of the OSA already assessed for this particular patient. Dr. Saurabh Das has elaborately discussed about the sleep study. Now, type of the OSA is also, it is my prerogative to judge whether it is static and dynamic. In his first presentation, my friend Dr. Uttam Agarwal has detailedly discussed about the static part, what he had followed in that particular patient, and level of obstructions to be determined by sleep endoscopy in our routine practice. Usually we don't do sleep MRI in most of the cases, And by DICE, we follow the nose and nasopharynx, oropharynx, hypopharynx, larynx, and the pattern of obstruction I am coming in a minute. And most of the time, there are both static and dynamic obstructions at multiple levels in same patient. Now, clinical and experimental evidence showed that reversible nasal obstruction, this is a very important message, reversible nasal obstruction like we find in allergic rhinitis is perhaps more closely associated with OSA than with permanent nasal obstruction like as we find in DNS. It appears that nasal obstruction, especially the reversible type, is associated with snoring and mild OSA, and nasal obstruction doesn't appear to be the main contributing factor in the majority of patients with moderate to severe OSA. There is a famous publication in European Respiratory Journal. They state that chronic nasal obstructions seem to play a minor role in the pathogenesis of obstructive sleep apnea and seem to be some relevance in the origin of snoring. So nasal treatment in OSA is very important. How do we treat? When patient comes after Cpap failure or non-compliance, we have to give utmost importance through medical management, nasal dilator, and surgical intervention to treat the nose. And management of allergic rhinitis, as we all know, by oral antihistaminic plus minus montelukast, anti-IgE antibody, topical corticosteroid, and sympathomimetic decongestant. So decrease in nasal resistance, improve sleep quality. BMJ, one publication tells that the effect of topical nasal fluticasone for at least 4 weeks results in decrease of AHI as compared to placebo. So although Cpap is the treatment of choice for moderate to severe OSA, the rate of adherence to this form of therapy is less than 70% in majority of the patients. So data demonstrate the need of good nasal patency during the patient's initial adaptation to the device. A subjective improvement of nasal obstruction, which in turn increase of Cpap adherence. There are several publications. One publication from Michael Friedman, significant decrease in the levels of Cpap titration after nasal surgery alone. And another publication tells that after nasal surgery, a significant decrease in nasal resistance and a significant increase in minimal oxygen saturation level during sleep are observed. However, no change was evidenced in AHI despite the decrease in Cpap titration pressure in this particular study. So, for our particular patient, this lady, we went for septoplasty to correct her gross DNS. As Dr. Uttam Agarwal told, there was severe gross DNS in that particular lady. So I went for septoplasty, endoscopic septoplasty, and turbinoplasty. But my dear friends and colleagues, there are other possible options for nasal pathology and reconstructive concept to treat and to improve the compliance. That means if there is a nasal polyp or mass, we have to go for functional endoscopic sinus surgery. Had it been there any adenoid hypertrophy or nasopharyngeal mass, we can go for endoscopic removal either by ablation or by any other device. And nasal valve collapse, we have to go for reconstructive nasal valve collapse repair. But after correction of the nose, suppose after septoplasty, in most of the cases, say I refer this lady back to my friend Dr. Arup Haldar again for continuation of the Cpap. But unfortunately, after a few months, patients could come back again for still there is a non-compliance. That means apart from nose, there are still possible other levels of obstructions. And why? What is the assessment of the level of obstruction is so important? Because we know severity of the OSA as assessed by PSG and AHI doesn't dictate the anatomy of surgery, and nose is pivotal but not primary anatomical factor in moderate to severe OSA. So the method we follow to assess the levels of obstruction is drug-induced sleep endoscopy. And let me share a small video with you how we basically conduct drug-induced sleep endoscopy. So I think I will show you the video later. Let me go to the next presentation. Suppose even after the assessment of by the drug-induced sleep endoscopy, we find some huge tonsil. We go for tonsillectomy. Huge palate, uvula and lateral pharyngeal obstruction, we go for reconstructive uvulopalato-pharyngoplasty. Huge lingual tonsil, we go for coblation. And at the level of the hypopharynx, as Dr. Uttam Agarwal showed, severe epiglottic collapse, we plan for hyoid suspension, advancement and epiglottictomy or epiglottopexy and supraglottoplasty. For different kind of hypopharyngeal obstruction, there are different kinds of permutation and combination of surgical procedure, what we can offer from our side. But the thing is, even after that, had it been there is a significant structural block from the container and the content issue, whatever the softer surgery we offer from sleep apnea point of view, we actually aim to reduce the content. But if there is a strong significant compromise of the container, that means if there is a significant retrognathia or the compromise of the overjet and overbite, we have to further assess to whether we need to do some skeletal procedure for these patients to offer them a better compliance of treatment and for adherence of treatment. So to assess the skeletal structure, we do lateral cephalogram, OPG, and also CT face. Of late, we have started doing different measurement by the sagittal reconstructed view. And after doing all these, our planning and homework, we offer different kind of skeletal procedure like maxillomandibular advancement, advancement genioplasty, and maybe even maxillary advancement, isolated maxillary expansion dome, that is distraction osteogenesis and maxillary expansion for the framework of the nasal improvement. Because in this kind of skeletally compromised patient, unless and until we it is very difficult to offer, forget sleep surgical success, to make the patients adhere to Cpap even. So take home message is lifestyle modification is very important. We have to give obesity aspect management. Cpap is the first line gold standard treatment for OSA management, and increased amount of evidence supports the proposal of target driven surgery for properly selected OSA patients, and more EBM studies are recommended. And the current and future trend is the 12th nerve pacemaker, and the candidacy is moderate to severe OSA with a failed Cpap, with a BMI of less than 32 and no complete concentric collapse on drug-induced sleep endoscopy. The Western world is now offering hypoglossal nerve stimulator pacemaker. And let me just see whether I can show you that video. Probably we have time still. So let me show you the video of the sleep endoscopy, how we do drug-induced sleep endoscopy. We take the patient to the theater in presence of my anesthesiologist and my sleep physician friend, Dr. Arup Haldar. We make the patient sedated by propofol in most of the cases and occasionally by Dexmed. We make the patient simulated sleep within the theater, not anesthesia, it is sleep actually. Patient goes to sleep. We do de novo. Within the theater, we do Eeg monitoring and to assess the level of the sleep, N1 or N2, and hope you could follow. The patient is snoring. and we see exactly velum or oropharynx or tongue base or epiglottis, exactly where are the blocks. We validate our study by doing simultaneous PSG and BIS monitor. BIS monitor is this monitor. This is the BIS monitor, bispectral index monitor, which guide us about the level of sedation so as not to over sedate the patient. So patient is snoring. We are doing the fiber optic flexible scope, and then the real-time assessment exactly during night time. What are the levels of the block patient encounter every night at home? So let me stop this and share with you another video. This is just to give you an idea of the drug-induced sleep endoscopy, how it looks like. So I think there is a problem in opening the file. So I think I could give you an overview, give an insight of exactly what is our modern ENT approach to tackle this kind of Cpap failure patients, because significant collapse at the level of the tongue base and the epiglottis are a very important issue where the patient might encounter significant problem. And not only to correct the nose, we have to offer and we have to keep our overall holistic approach. And in tune with my friend, colleague, Dr. Saurabh Das, not all sleep disorder patient are obstructive sleep apnea. We have to rule out other disorder also. And not all surgical patient are only nose. And from all surgical point of view, it is my prerogative, it is our prerogative, when we have to keep an open mind, when we should refer our even surgical patient after doing some limited procedure as per the patient's expectation and demand back to you again to continue Cpap therapy. Because last but not the least, apparently Cpap therapy is the gold standard management. Our surgical offering, basically what we do is to improve the Cpap compliance, but in severe surgically correctable lesion of late, the current guideline is we can do surgical procedure even going for Cpap trial. Thank you very much.
DJ sir, mic is muted.
Hello.
Hello, yes, sir.
The next speaker. Hello. The next speaker is Dr. Bikram Sarvai. He will present some interesting cases of obstructive sleep apnea.
Sir, please invite Dr. Srivastav. He is
Dr. Srivastav.
Yes.
Serially, it was otherwise. I invite Dr. Deepak Srivastav, is known to me for a long time, and I invite him to present some very interesting cases, and he has come all the way from California. And please present your cases.
Will you be able
Professor
to?
of Medicine, Sleep Medicine, Pulmonary Critical Care. Is
will you be able to play my video?
And Davis, California, USA. Thank you. Please.
Dr. Jyotira, would you be able to play my video?
Yes.
Kaushik, please play the video. Kaushik, can you hear me?
Yes.
Yes, I'm playing.
Okay.
Thank you.
Yes, you are audible, you are visible.
Yeah, thank you. And I'll not be able to participate in the question answer session. I start a 8 o'clock meeting. So 8:30 India time. So I'll be taking off after the presentation.
Today, we'll have two illustrative cases of clinical importance. As we know that the sleep medicine is founded on the basis of multiple specialties, and each specialty has its own representation, but there is also sometimes very complex interplay. Today, my goal is to discuss this multidisciplinary dimension of the practice of sleep medicine. At the end of this presentation, we will understand potential layers of complex interplay in working up the sleep disorders and enhance the sensitivity to suspect atypical pathophysiology in seemingly simple presentations. We will understand the implications of empiric treatment modalities that may be appealing on the face value, but may not be all that good for the patient. Let's start with case 1. A 24-year-old female experienced episodic excessive daytime sleepiness for 8 years. Many times she sleeps for 18 hours and then takes another nap for 2 hours, so about 20 hours of sleep throughout the day. And this cycle repeats many times a week, and there is variation within a week. She wakes up tired and fatigued and occasionally gets morning headaches. Her symptoms alternate with the periods of no daytime sleepiness within that week. She cannot report a consistent bedtime and rise time because she is not working. She prefers staying awake at night and calls herself as a night owl. Her pertinent past medical history is hypothyroidism, for which she takes levothyroxine, and bipolar disorder, for which she takes lithium. Pertinent lab data is thyroid stimulating hormone 2.5 milliliters per unit, free T4 6 micrograms per deciliter, and lithium levels 0.2 milliequivalents per liter. And here is her sleep diary. We can look at this sleep diary. Let's first orient ourselves for people who do not know what the sleep diary orientation is. It is the American Academy of Sleep Medicine standard sleep diary that is recorded for 2 weeks by the patient. And here's Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, 7 days of the week, first week, and 7 days of the second week. And you can see when the patients sleep, they mark it with their sleep time. And here in this particular case, we'll focus on the night time here. So this patient sleeps during the daytime. Here is the daytime naps that you can see week after week. And then you can see the long sleep period during the night. And it is variable through the first half of the week, and then she's not sleeping during this part of the night here on few days or few nights rather, and then again she becomes extremely sleepy, that you can see goes into the second week, and this cycle continues to repeat. So as we can see, this patient has variability within the week of excessive sleepiness or long sleep periods interposed with lack of sleepiness during a few nights. This last slide shows what is called the ectogram. And this patient was given the ectogram. Here the periods of sleep are coded with the color. And again, this is the days of the week. And you can see the wake up time with the level of activity with the black bars. And rest is lack of activity. So black bars are down and the color is denoting the sleep period for the patient. And what strikes here is the irregularity of the sleep period, just like we saw on the sleep diary, and therefore ectography can be a confirmatory test of the patient condition. So based on this, we have to figure out what her potential diagnosis is based on her presentation, history of present illness, and the basic workup that we have done. Is it a circadian rhythm disorder, delayed sleep phase time? She's the right age, maybe slightly older. Is it narcolepsy with so much sleepiness? Is it hypothyroidism? She does have a history of hypothyroidism. Or is it bipolar disorder? Well, out comes the case. This was a case of bipolar disorder. And when we were looking at the labs, we saw the lithium levels were slightly low, and they were subtherapeutic. Apparently, the patient was not taking lithium at the time. and her bipolar disorder actually researched. In this particular case, the sleep improved with the increase in the lithium doses and resumption of her therapy. And once the levels normalized, here is her follow-up ectography. Let's zoom it. And the ectogram here, now you can see the level of activity during the daytime, and then patient goes to bed and sleeps throughout the night. And this is day 1, day 2, day 3, day 4, day 5, day 6, day 7, and through the week, her symptoms improve and her irregular excessive daytime sleepiness resolves. What are some of the learning points out of this case? Excessive daytime sleepiness is more common in unipolar depression, we all know, than the bipolar depression. Well, as I said, that the multidisciplinary foundation of sleep medicine dictates that people who have the background of psychiatry will find this case very easy to solve, because they noted that the patient has a history of bipolar disorder. She's on lithium and the lithium levels are low. Obviously, this is going to exacerbate her bipolar symptoms, especially the mania or hypomania phase. Significant percentage of the bipolar depression patients also have excessive daytime sleepiness. Sleep-related complaints may persist even after the mood-related symptoms are controlled. And this is very important to understand if a patient comes in with the psychiatric history and they are on certain medications. As a habit, we sleep specialists review all the medications. And here in this particular case, the same thing happened. And especially if the lab values are provided, we have to pay good attention to whether they are normal, in toxic range, or below normal or subtherapeutic range. There is genetic association between the circadian rhythm related sleep disorders and the bipolar disease. So this is work in progress, I should say, but the relationship exists, and there is some documentary proof, and that I have added in our literature in the next slide. The delayed sleep phase syndrome, which was one of our differential diagnoses, as you all know perhaps, that it has a prolonged sleep latency if the patient is sent to bed at the conventional social bedtime, because these patients tend to stay up until 1 or 2 a.m. in the morning before they go to sleep. And they have appropriately so a late rise time because they like to take their full sleep period, which is 7 to 8 hours. But once they fall asleep, sleep is totally uninterrupted, and it is a full night of sleep, except the whole phase of the sleep is shifted or delayed. Therefore, this case is not a delayed sleep phase disorder, because clearly we saw the irregularity and there is no consistently late sleep phase. Could it be narcolepsy? Well, narcolepsy certainly has excessive daytime sleepiness, but the normal sleep and wake times and the sleep duration during the nighttime is relatively stable. They do have interrupted sleep if they have narcolepsy. Hypothyroidism is more controversial regarding the fatigue versus sleepiness. However, it has not been known to cause unusual sleep pattern that we saw in this particular patient. Here are some annotated references for your review. Hypersomnia is comprised of 2 separate subgroups: long sleep and excessive sleepiness. Long sleep is characterized primarily by the long bed rest duration, so patient tends to stay longer in the bed as opposed to sleepiness. Excessive sleepiness is not associated with longer sleep or bed rest, but predicts relapse of the mania or hypomania. And then there is another 2008 reference in American Journal of Psychiatry, which showed impaired sleep can induce and predict maniac episodes, something that we saw in this particular case. And then a recent, or rather more recent 2014 publication shows that the bipolar disorder patients have abnormal activity rhythms and sleep efficiency, which are associated with abnormal working memory-brain response. These preliminary findings support the notion that the sleep and circadian system is important in the functional brain deficits among the bipolar disorder patients. That concludes the first case. Let's go on to the second case. Historically, this is a 59-year-old man who presented with violent nocturnal behaviors reported by his wife. The frequency of these episodes is lasting and increasing for last 5 years. Typical behavior is he talks in his sleep, shouts, gestures, kicks, throws punches, and sometimes hits his wife during the sleep. Unfortunately, otherwise, during his wakefulness, he is a very nice, kind gentleman and is totally unaware of his behaviors that occur during the nighttime. This behavior occurs many times every night to the distress of the wife and, of course, the patient once he hears about it. There are no complaints of tongue biting, incontinence, or wandering. I'm sure at this time you are guessing the diagnosis. His sleep is non-refreshing, so he is tired in the morning. He does have a history of loud snoring and frequent daytime sleepiness. He has gained about 75 pounds weight in last 8 years, and he does not report any cognitive decline. He does not report any leg discomfort or muscle spasms and does not report cataplexy, sleep paralysis, or hallucinations. He is not taking any medications at this point. His Epworth sleepiness scale shows a high level of sleep debt, 16/24. His physical examination shows narrow pharynx with elongated soft palate, BMI is high, blood pressure is high, and there are no signs of Parkinson's, cerebellar sign, or oculomotor abnormalities. Here is epoch from his Rem sleep arousal, and as you can see that there is a obstructive sleep apnea episode leading to the arousal here. And we will see the video on the next slide, and hopefully it will work, which in fact shows his behavior during these episodes of obstructive sleep apnea with arousal. It's a short video, bear with me for 30 seconds. You can hear the raspy breathing. And here he picks up and gets the episode. Apnea hypopnea index is, in this particular case, is 59 events per hour. Arousal index is 66 events per hour. Lowest oxygen saturation is 62%. Significantly reduced delta sleep or N3 sleep percentage. Event occurred with the arousal at the end of the apnea during the REM sleep. No events were noted during the arousal from the non-REM sleep in this PSG. REM sleep did show atonia, which is very atypical of the diagnosis that you were thinking. There is no increased tonic or phasic activity in the EMG channels. Again, very different finding that we were expecting based on the history and the video PSG. So this is very important to really look at the PSG and the timing of the event in context of the REM sleep versus sleep apnea. So is it REM behavior disorder that we were suspecting in the first place? Sleep terror? Well, we understand that sleep terror tend to occur during the non-REM sleep mostly. Sleepwalking, another non-REM. Parasomnia. Is it nocturnal seizure? But we saw the well-formed activity on the EEG with the REM and did not see any seizure focus. Or this is obstructive sleep apnea with pseudo-REM behavior disorder. And in fact, this is a case of severe obstructive sleep apnea with the REM behavior disorder or pseudo-RBD. And this kind of episode can mimic the RBD and can be mistaken. The patient can be started on medications that we'll talk about just in the next slide. OSO pseudo-RBD should be considered in the workup of the violent dream enacting and complex behaviors. Other conditions with excessive daytime sleepiness and abnormal behaviors show up. There is narcolepsy with cataplexy associated with RBD, obstructive sleep apnea, regardless of the pseudo-RBD with concomitant real RBD. So you can have that combination. Please do not mistake these two entities. They can occur together, but the PSG will be discriminative, and it will suggest whether we are dealing with a situation where this is pseudo RBD during the arousal or it is actually occurring during the REM sleep. Idiopathic hypersomnia with the REM behavior disorder or medication-induced REM behavior disorder, especially with the mirtazapine, these cases are prevalent. Is it sleep-related seizures, which will require further workup, and idiopathic hypersomnia with the non-REM parasomnia can present like this as well. There are a number of references. This work has been done and multiple cases have been documented. It is important to understand the value of not treating with the empiric therapy, because if we make a clinical diagnosis without doing a PSG and without reviewing the PSG, just like we reviewed in this case, it can be counterproductive, because if we make a clinical diagnosis of REM behavior disorder and start empiric treatment with clonazepam, which is a long-acting benzodiazepine, guess what can happen? This patient has severe obstructive sleep apnea with 59 episodes every hour. You're going to worsen it because the benzodiazepines are myorelaxant. They also increase the threshold for arousal. That means the patient will have a longer period with oxidative distress and will not wake up with the significant oxygen desaturation, in this case was in 60s, that can be detrimental to his cardiovascular function. Therefore, it's very important to understand the underlying pathophysiology. Patient should be evaluated not only with the history fiscal examination, but also video polysomnography, and good analysis of polysomnography will yield a diagnosis. I would like to thank you for paying attention.
Thank you very much, Dr. Deepak Srivastava, for presenting two beautiful cases. Thank you very, very much.
Thank you, sir.
Sir, DJ sir, Dr. Srivastava will be leaving, so if you have any question, you can ask him.
In fact, these two cases are very, very, very interesting. One lithium, or even polar disorders having such circadian rhythm and disorder, and the RB OSA with pseudo RBD. In fact, people might ask you to explain what is pseudo RBD and RBD, just because this is a beginner session, and they would like to know that the difference between pseudo RBD and RBD.
So let's first quickly talk about the RBD itself. RBD itself is a disorder where, in general, sleep has main two types: non-REM sleep, which is about 75% of our total sleep time, and REM sleep, about 20-25% of our total sleep time. So that's demarcation is kind of arbitrary. And sometimes in our three stages of being, or wakefulness for 16 hours and sleep for 8 hours, this is distributed accordingly. So there are very specific boundaries that define our wakefulness, our behavior, etc. Similarly, there are very clear boundaries between the non-REM part of the sleep and the REM part of the sleep. In many of these parasomnias, these boundaries are very faint. They do not have that strong demarcation. And the symptoms and the characteristics of one stage begins to get into the other stage. So for example, to make it short, in REM sleep, our body is paralyzed and we dream. Well, in the parasomnia that are related to REM, especially the REM behavior disorder, the wakefulness symptoms or the characteristics enter the sleep. So now the person is dreaming, which is the characteristic of REM sleep, also known as dream sleep. So person is dreaming, but then the body is not paralyzed and they start acting their dream. When they act their dream, and most of the time these people are very nice people in their wakeful life, but they dream about they are defending a family member from some predator, or they are fighting with somebody. And in fact, that fight begins to show in physical activity during the sleep. And in fact, there are very, very interesting cases. And if you will interview your patients in the clinic, you will find these cases. This is very prevalent in the middle-aged men. And also know that this is also prevalent, not as much in females. So you just have to look for it. Treatment is very easy. You start clonazepam. And I made that comment in the last slide that please do not do that, because you could be missing it, because there are disorders that I listed on the last but one slide, number of slides, the number of differential diagnoses that I alluded to that can present like a REM behavior disorder. And this particular case was an example of severe sleep apnea with the arousal, and that led to symptoms which appeared or will mistakenly lead you to believe that this is the REM behavior disorder, and you don't have to treat it with clonazepam because it is not. It is a disorder of arousal secondary to obstructive sleep apnea, and that's what was happening. So you have to treat the obstructive sleep apnea. The disorder will go by itself. So,
and more so, the patient doesn't have any degenerative disease or neurological disease. It doesn't have any Parkinson's disease, as
yes,
it happened in REM behavior disorder.
Yes, sir, that is correct. But the Parkinson's disease or other neurodegenerative diseases, the REM behavior disorder can predate them by 10 to 15 years. So somebody who has a real REM behavior disorder today, down the road, 8, 10, 15 years later, can actually develop Parkinson's disease. So it has bilateral relationship. You can have a Parkinson's patient who is known and now begins to have a REM behavior disorder, or other way around. But the PSG and very careful attention to the PSG actually will make a correct diagnosis whether we are dealing with a pseudo RVD or RVD. Right. Fortunately, these cases are not very many, but we have to have that sophistication, that astuteness, in order to read the PSG and read between the lines, that I would like to say. Also, I know time is short, and we have a major surge of COVID here in the United States. Yesterday, we had 1 million people convert positive in 5 days. So within 5 days, 1 million people. Our ICUs are 3 times the capacity, and I start this Sunday morning here, and in 2 minutes, I start my ICU committee meeting, because we have to triage these patients and move them to other area hospitals. So, and that's why the rush. And I really admire that you allowed me to speak with everybody today. All the speakers, I must compliment you. I was listening to every talk. It was 5 a.m. when you started here. I woke up and attended. Amazing talks, wonderful material. Something that I like to hear. If I can learn, anybody else can learn. And the material was so well organized and so well presented that I'm totally ecstatic about it. So congratulations. I'd like to say goodbye because I have to get on my IC committee meeting. Thank you and good luck. Please continue.
Thank you, Dr. Srivastava.
Thank you.
The next speaker is Dr. Bikram Sarvai. Dr. Bikram Sarvai.
Thank you very much, Dr. Roy. It's a pleasure.
Yes, let me introduce you. Though you don't require any introduction. For his introduction. Bikram Sarvai is an MD, and he it has been transversely placed. Right. His area of interest are pulmonary tuberculosis, bronchial asthma, COPD, sleep apnea, bronchoscopy, and autoimmune lung disorders. He is currently associated with National Heart Institute. Go on, Bikram. It's nice to listen to you. It's unique lectures, usually unique case presentations. Please.
Yeah, thank you. So thank you very much, Dr. Roy, for, can you see my slide on the screen?
Yes.
Okay, so this was a slide that, kind of introduces me, but you did a great job. Thank you very much for introducing. You are a senior colleague and a friend and an inspiration for us in the sleep medicine for many, many years, over 2 decades, or probably more than that, because even I've grown old now. So it's maybe around a silver jubilee year now, 25 years. Thanks also to Saurav to invite me to this workshop. And above all, it's a great effort from Dr. Partha Bhattacharya and Arup Haldar. And just like we had the feast of 2 beautiful cases. So I was asked by Saurav to, arrange some sleep medicine cases. He asked me to, but I thought I'll take some montages and try and explain. So let me do this. These are my cases. This is Compumedic's sleep lab, which I have, and this is the neuro channels here, and this is called the montage selection of the neuro channel. These are the I channel, this is the EEG channel, this is the ROC right and the left I channels, this is the EMG, this is ECG, oxygen saturation, airflow, thoracic, abdominal band, this is microphone, this is position, and these are the leg EMG. So this is a typical kind of a montage that we all select in a type 1 level polysomnography. Over here on the top, we see a hypnogram, and we have many ways to do this. So here I put it as cardiovascular consequences in a case of sleep apnea. Here is the name of the patient, and you will see here that there is an arrhythmia. There is a kind of atrioventricular, the P wave is gone, and this patient had poor ejection fraction, and he had a drop in the oxygen saturation because of a sleep apnea. And you can see that there is a continuous kind of a movement of thoracic band. The abdominal bands are a little low. And then you will see that the person starts to snore, and then there is a small micro arousal, and then there is a snoring here. And you can see here, there is initially, this is called obstructive sleep apnea with increasing effort. There is a leg movement, there is an arousal. And once there is an arousal, then you will see that the oxygen saturation continues to fall. So the interesting thing that I want to tell people is that in sleep apnea, the saturation does not fall immediately at the time of apnea. It actually continues to fall before after the apnea ends, and that is because there is a lag phase in the oxygen saturation and the stoppage of, and then the person starts to breathe, and then the oxygen saturation picks up. So this is the reason why I took this slide. The other thing is, this was way back. This is a study that I did with my colleague, Dr. Bose, in the initial time of, I think this is 1999. If you see here, February 1999, this was about a patient whose wife used to come to my OPD as a medical representative. And one day she came and she said that my husband has to have a defibrillator implanted, and my electrocardiography colleague, Dr. Anil Saxena, asked that he should see me because I had joined escorts at that institute, and there was more cardiology cases. So if you can see here, this guy has a tachybrady arrhythmias happening. This is a sleep montage, but that's what I'm trying to say, that what was actually happening to him. The story is that this man would go for work, and he would ride a bike, and he would sleep while riding a motorcycle, a YSD motorcycle, and he had 2 or 3 falls and had terrible injuries. Once he had a fracture, and once he had a mild head injury, and they were scared that he may actually die in an accident. So we did a study, found he had obstructive sleep apnea, and he was seriously desaturating, and he was having tachybrady. So when you have a sleep apnea, you may have a little bradycardia, and then suddenly when you wake up, then you will see this kind of a tachycardia. So it's a bradytachyarrhythmias. And then I treated him with CPAP. And then you see the saturation here is completely above 90%. His breathing is normal. He's going into REM sleep. This is phasic REM that you can see. And look at the heart. The heart is beautifully, has no arrhythmia at all. It's complete REM sleep, normal sinus rhythm restored. This patient, we put him on CPAP and had a normal life. He didn't require a defibrillator. So this is what I'm trying to say, how much somebody changes and how people are suffering from such disorders. So if you see here, this is the CPAP level. And if you can see, the CPAP level is around floating between 12 and 10. If you see here, so this is 20 CPAP and this is 2. So you can see it's right in the middle, and see how beautifully he went into REM sleep and had a normal sleep. Next, I will see, this is another one of my very landmark cases. He came from Bangladesh, very close to you, from Dhaka, and Noibul Islam, his was name. And he came, and his interesting story was, again, he was sent to me by Dr. Saxena in Scott Heart Institute, who is our electrophysiology expert in cardiology, very, very renowned chap. And this man came, he had a bypass surgery done at Trinity Hospital, London, and then had 2 angioplasties done at Scott's Heart Institute. And he was, I think, about 43 years old man, and he came and he started weeping. He's a very successful businessman in Dhaka, and we had a lot of patients coming from Dhaka at that time to Delhi for and he started weeping. He said that I cannot survive, I will die, because doc, I have had an angioplasty done at the age of 35, and by 40 I have 2 angioplasties and stents, and I have 3 major stents, and the intervention cardiologist has now sent me to Dr. Saxena to give me a pacemaker. So my heart is completely rotten. How will my child and my wife will survive? And if you see here that when we did his sleep study, he was sent to me because he had typical metabolic syndrome kind of features, and Dr. Saxena thought that I want to see whether he has sleep apnea. So that was the importance of multi-modality, multi-speciality hospital. And if you see here, these are large snores. If you can see, they're ripping through the whole montage. The saturation is dipping down here. So if this is 80%, and you see how this is phasic REM. And when I did a study, and this is classical paradoxical movement of the chest and abdomen. So the chest and abdomen starts to move opposite direction. So it goes up and this thing. And if you see this, this is the next slide. And as soon as he REM, so this is the next montage, he goes into phasic REM, and then you see how much bradycardia he starts to develop. And the bradycardia again is coming as he is picking up, and this is classical paradoxical breathing. The airflow is complete cessation, and you see that he starts to have in REM sleep. This is the REM sleep, and he started to have bradycardia, and for which he was advised to have a pacemaker. And so I put him on an auto CPAP was there, and then discovered that his arrhythmia had improved a fair bit and became very regular. And he had in the N3 stage sleep, which is delta sleep. But he continued to have snoring because he had terrible problem. But here, if you see, his breathing became rhythmic. His breathing become, in sign with each other, and he had a normal saturation, but he was still getting arousals. If you see, there is a leg movement here, and there is continuous mild snoring. Now, if you see again, this was what is happening to him. And then what we did was that I actually titrated him. If you see here, let us look at this pressure. The pressure, if you look at it, is close to 20. So it's about 18. So what I thought was I will put him on a bi-level PAP, and I gave him a C-level, E-level PAP at about 16. I remember from my records, and the E-PAP was 25. And this was what was happening to him. And I left this patient, and my technologist had never ever thought that he thought I will blow this man. at 16 centimeters of pressure. And this is, I'm talking about early days, the technologists were not very well trained. I had somebody who was working with me for last 5-6 years, but he had never seen this kind of so he thought this patient may not have a problem. So what he did, he pulled down the BiPAP at night. So if you see this, this is about 5 o'clock in the morning. Okay. And you see, he goes into REM again, and you see this huge heart block here. This is a 11-second heart block. And this is the reason why he was asked that his bradycardia was such big. And this is happening because he was desaturating. He again went into sleep apnea, and he was having paradoxical. And so I actually, the next day when I came and I said, boss, why did you under titrated him, my technologist? He would have probably died in my sleep lab. He survived a bypass and 2 angioplasties, and he would have died in a sleep study. And I was not so senior in a Scott Heart Institute. So I thought he would have ripped off my career, and they would have said something happened in the sleep. You treated him with CPAP and BiPAP, and this guy died. So these things can happen. I want to caution the beginners that if they are dealing with a cardiovascular issue or nobody comes with a diagnosis that I don't have heart blocks happening in my sleep, but these things can happen, and don't just trust your technologist. Something can go wrong, and these kind of things happen. And now on that day, we then started him on BiPAP 16 and 24. And 1 year later, he brought lots of gifts to me. He didn't get a pacemaker, and he said, Doc, I'm living another life. I've never lived like this, and I'm ready for the second wife. I still remember in 2005 his dialogue in my OPD, 15 years from now, but he said, I'm ready for the second wife. So this is what I wanted to show in this cardio. Look at this one. The same guy, and with under titrated BiPAP, paradoxical breathing reappears, 11 seconds of heart block. Same guy, Noibul Islam from Dhaka, and same REM physics sleep. And this is what happens. This is what happens. Now, again, this is another patient. If you will see that in this part of the EMG, you will see that there is a classical myoclonus activity, not myoclonus, but muscular activity, which is happening across all neurochannels, whether it is EEG, whether it is LO, ocular, and EMG. So all neurochannels have similar kind of burst of activity. And my problem was that I had put him on an auto CPAP, and I was titrating him for sleep apnea. He was desaturating, but the problem was that he was having frequent arousals. But just before the arousal, so if you will see here, that the auto PAP is not able to push anything. It is lying at 0 level and is not able to, even though the patient is desaturating and even have this kind of a muscle activity. So I was actually titrating him on site, and there was a curtain between him but every time he would actually make a leg movement and wake up, and my auto PAP had not started to function. And if you will see here, the time is nearly 4 o'clock in the morning, and I've been sitting whole night with this man, and I didn't know what was this. And I didn't have the experience of noticing this thing was repeatedly coming. And then I realized that he was making a chattering kind of sound. So he was having bruxism. So this is classical bruxism. So he had sleep apnea with bruxism. And when he would clench his masseter, and he would then wake up, and that arousal. So he was continuously shifting. As soon as he would go into sleep, he will brux, and the bruxism will create him arousals, and he would desaturate, and he would get in the sleep-wake transition, he would wake up with bruxism. So what was happening is that the CPAP was not able to find the resistance, and it was not able to increase the pressure. And only when I put him on manual titration that I was able to see that he slept, and he was able to cross over from bruxism to normal. And then we gave him a CPAP, and then he led a fairly life. So I know for 5 years he used to come to me every year, and he was doing very well, and his quality of life did improve. So this is a case of bruxism, which can happen alongside obstructive sleep apnea, hypopnea, and you will see that bruxism, and these are complex sleep disorders. It's a sleep-wake transition issue in the stage 1. And here, if you put these kind of complex patients on auto CPAP, the patient may be, the machine may be running and everything is happening, but the patient is not getting treated. And here, I want to also show that here you see REM sleep. The CPAP titration is done. The person has gone into REM sleep. The ECG or the heart rate is perfectly normal. The airflow and thoracic movement and abdominal movement all in concordance, and the saturation is perfect. There is a continuous CPAP pressure of 6 to 7, and this is no leg movements, and this is ideal titration. This is the time when you can go home saying that my patient is titrated, he has gone into REM phasic sleep, and everything. So this is a slide which has been kept as a montage to say what is ideal titration and what is the time when you can say that I have fully titrated this patient on a manual CPAP. So this is what I wanted to show. Again, another patient, he again was having a problem with auto CPAP, but when he was manually titrated, he had a long, this huge kind of REM is called rebound REM. This is all phasic REM. The EMG shows a flat line. So there is completely classical REM sleep. The saturation has picked up. There is a CPAP pressure of 16 to 17, a hugely obese and classical CPAP patient, obstructive sleep apnea patient. This is another lady, very complex. She had to be titrated on a BiPAP, and here you will see stage 2 sleep, and here you will see 94-96% saturation. The titration of BiPAP has been done. It is ranging between 16 to 20. The thoracic and the abdominal bands are classical. There is no paradoxical breathing, and she's ideally titrated. No snoring at all. There is no limb movement. Now, there is another patient who I would show, and this is how when you treat somebody on a CPAP, and if you see here that the pressure between 10 centimeters and going up on 10, 16, 14, and this is like an auto CPAP titration, then you will see how does a respiratory effort related arousal can come in a PAP titration when you are viewing. So what happens is you've titrated somebody, you're seeing the saturation is within the range, so it is 93%, 90%. You are happy with the saturation. The breathing is, the heart rate is perfect. The brain activity is classical stage 2. But you'll see micro this thing. But if you have a look at what is happening at the breathing pattern, so you see here that there is a normal breathing, there is sinusoidal breathing. These are thoracic movement, airflow, and abdominal movement. And then suddenly you will see that the breathing effort starts to die. And then there is an increase in the degree of effort of breathing. And as somebody reaches a threshold of deep breathing, this creates enough respiratory effort that triggers the brain to create a respiratory effort. And this you will see is what is classical called respiratory effort related arousal. So there is drop, there is initial, one can say is almost like central apneas. Then you will see that the patient starts to make an effort in the thorax, and the degree of effort becomes more and more. So this is an indirect way of saying how a respiratory effort can increase and create an obstructive. So this is mimicking respiratory effort related arousal in a case of maybe suboptimally titrated even at 14 centimeters. And these can keep giving these patients arousals. And when we say we have titrated CPAP, why is the person still sleepy in the morning? It may be because he's still getting, you have made a very severe sleep apnea into a respiratory effort related arousal, which means that you have reduced the severity of the sleep apnea, but the symptoms have not been alleviated. So this is classical of saying that from a very high spectrum of obstructive sleep apnea, you brought it down to another patient. If you'll see a CPAP level ideally titrated, this is an auto CPAP titration. Initially there is a floating, and then you see even in some patient, auto CPAP does very well, and you see huge amount of these REM sleep, and you will see that these are all what is called rebound REM. Do I have some time, or I'm done? Okay. So this is what is going on, and then there is another. I wanted to tell people who are very sure that the auto PAP works. Then you will see here that there is a desaturation here. There is a pressure already. So this is an automatic CPAP. But if you will see here that in spite of a CPAP generated by the auto PAP, the person continues to have obstructive apneas and central apneas. And when somebody gets central apneas with a CPAP, it becomes complex sleep apnea. So it is marked as central apnea, but this is called treatment emergent sleep apnea. And at that time, in those times, this in 2005, treatment emergent sleep apnea was not even known to the sleep physician. So I was actually observing this phenomena, but I really didn't know what was happening to my patient. While I'm treating these people, they're still desaturating. So treatment emergent sleep apnea I was seeing, but I had no clue that this is an entity. Again, I will show you that there are different kinds of automatic CPAPs. Here it is a D-Wilbis format. Then I started on him on ResMed AutoMap. And here you will see that again, respiratory effort related kind of arousal, desaturation, saturation happening in spite of CPAP. And then you will see that this kind of a thing is continuously happening. So even if you put these patients on AutoPAPs, you will realize that some patients have such complex pathophysiology of sleep and obstructive sleep apnea that AutoPAP cannot actually treat all of them. So these are the reason, even whether you take from one company or the other company, two companies, this thing could not treat it. Again, now this, you see complex sleep apnea or treatment emergent sleep apnea, you will see that this lady was poor heart function. She was a case of severe mitral regurgitation and used to be in heart failures. And if you see here, this patient had central sleep apnea because of heart failure, desaturation, complete flattening of line, and then mixed apneas, this thing. And if you will see here that the pressures, the machine is able to give some pressure, but as soon as the mixed apneas come, there is no triggering. So no matter what you do, you don't get any. So you are seeing this kind of a behavior. And this was again treatment emergent sleep apnea. Again, if you see this lady, Satyavati Uppal, you will see here multiple atrial fibrillation happening, mitral regurgitation. This is stage 2 sleep. And if you see here that this is central apnea, I'm giving her some bilevel treatment that I'm trying to encounter her desaturation. But the problem with a simple BiPAP is if it is not time related, then in a central apnea that happens in a heart failure patient, it does not trigger the breath. And if it does not trigger the PET, the simple BiPAP is not able to deliver. So what she needs probably would have been a timed. So if we set a respiratory cycle, there would be a breath delivered in these patients. And so you are seeing here treatment emergent central sleep apnea with bilevel titration. And even in spite of bilevel titration, simply because there is central apnea and there is no respiratory effort, it does not trigger the patient BiPAP, and then the BiPAP starts to fail. And this is a periodic limb movements. I will show you. This is periodic limb movement, which is followed by just a minute. So if you see periodic limb movement here, there is an anterior tibialis and this thing, periodic limb movement, but there is no arousal. The sleep is completely first class. This is like a delta sleep. The person is sleeping, there is no arousal. Some periodic limb movements will create a sudden kind of rush of EMG activity, EEG activity, and you will find there is an arousal. Now, you can have CPAP induced periodic limb movement while treatment of sleep. So here, if you see the saturation is become ideal, there is a 9 to 10 centimeters of water pressure. The person is sleeping, but there is sudden burst of periodic limb movement just happening because you are treating these patients with a CPAP. So CPAP can actually induce periodic limb movement in patients. Again, you will see here is CPAP induced periodic limb movement in a 2-minute montage. And periodic limb movement means there will be a periodicity, there will be a stereotypical this thing happening. So this is what I wanted to show. Thank you very much, and thank you very much for your kind attention and bearing with me. Your microphone is muted, Dr. Roy. We can't hear you.
Thank you for presenting such beautiful cases of tachybrady arrhythmia, under titration and treated with BiPAP, OSA with bruxism, OSA with RERA. And what is to be done here? What OSA with RERA?
So that's what I'm saying. And when I used to see them, the whole thing happened. This is happening because there is continuous, when you're trying to titrate these people, ideally you want this thing to happen, but their neurological triggering and neurological derangement has happened over years. You cannot correct their sleep apnea in one day. So if you give them a kind of an ideal CPAP, over a period of time, their triggering and everything starts to settle down. Right. So whether it is treatment emergent sleep apnea and this thing, you cannot ideally and perfectly treat anybody. There will be a little variance.
That's true. That's true.
And then there is, once they start using these CPAP, then over a period of time, a lot of these things start to settle down.
And in manual titration, timed BiPAP should be there to see these complex sleep apnea. Absolutely. You must have in manual titration.
Dr. Roy, at that time, I didn't even knew what was happening to this. The more I would increase the PAP pressure, the more
that is the usual thing that should happen. Thing.
Sometimes,
and CPAP induce different disorders, limb movement and others. Thank you very much, very much.
So I've seen this pattern happening with me in COVID, in sleep apnea, and now with COVID. We are completely dependent until the someone discovers the rate for us. We are not able to say. We always say that we haven't seen this thing, but almost all of us have seen these phenomena and have treated and have been flabbergasted because we don't know what is happening to our patients. Why are they not getting better?
Thank you very much, Bikram. Thank you showing beautiful cases. Thank you. We may call end of this session. Thank you very much. Thank you, Dr. P.S. Bhattacharya.
Please look at any question from the audience. I'm not sure whether people are still there to question or they've already posted some questions.
Is there any question from the audience?
I think there are 2 comments. Sami Jayaraman, she says, any recent drug therapy to improve upper airway muscle tone? So she's asking about sleep apnea having any pharmaceutical alternative, and empagliflozin, anti-diabetic in sleep apnea. You people can access your Q&A area. You will find these questions answers.
There are 2 questions, sir.
Yeah.
Anybody want to volunteer?
What about the pediatric patient? Should we apply the same protocol? 3rd question.
Okay, so the first question is, any recent drug therapy to improve the upper airway muscle tone?
So first is that I can, make an attempt to answer this question. That is that this upper airway muscle tone is a dynamic process in these particular individuals who have a neurological. So when we are addressing people in a pulmonology conference, and because it's a breathing deformity or a breathing process, we feel that it's a respiratory related disease. But obstructive sleep apnea is a neurological process. It's a neurological abnormality, and it's a dynamic disorder, which happens because the brain shifts from wakefulness into sleep. So if we were to discover even a drug which would improve the tone of the upper airway muscle, we don't want this to happen in the wakeful time. We want this to happen in the sleep time. And in sleep also, as there are different stages of sleep, as the patients keep going down, in from stage 1 to stage 2, then delta sleep, and then REM sleep, the drug will have a uniform kind of a pharmacokinetic on pharma. So we can't, it's highly desirable that we can treat sleep apnea through a medicine, but medicine can only have a certain chemical way of reacting. It will not be able to detect whether the person is in REM or is in delta sleep or is in stage 1. So these therapies are desired, but it's very difficult to achieve, nearly impossible.
There has been several trials with the antidepressants and various antipsychotic drugs, but none came to be superior to CPAP, I think. And in all drugs, in all therapy, actually, there is reduction of AHI, but the oxygen saturation or the desaturation index remains same. So still we do not have a drug treatment for obstructive sleep apnea because the pathology is at the various level, not only the muscle tone, there is problem with the arousal index, there is problem with the loop gain, there is structural obstruction, a dynamic obstruction. So any drug cannot act on all these levels. Even the CPAP cannot act in all these levels.
I'd like to add something here, Olga, with your permission.
No, please.
So actually, there is, I mean, when we're discussing about drug, the drug which has the most amount of evidence is mirtazapine, which is a kind of an antidepressant. However, it falls way shorter than an ideal molecule, as Dr. Saraha sir has mentioned, that for treatment of obstructive sleep apnea. But mirtazapine has been found to have some little bit of evidence in a few cases. Thank you.
Can I take the pediatric question?
Yeah, please go ahead.
There was a question, what I have followed. The same protocol for the pediatric patients.
Yeah.
It's a very nice, interesting. The thing is, more or less, usually the CPAP is not actually our first line of treatment option for pediatric patients. Having said that, definitely we should go for maximum medical therapy, that is allergic rhinitis management for pediatric patients too. That too, including the conventional oral antihistaminic plus minus montelukast, along with mometazone or fluticasone nasal spray. After that, there is a conventional surgical management which is recommended for pediatric patients to treat the pediatric OSA, that is tonsillectomy and adenoidectomy. But tonsillectomy and adenoidectomy is actually not the final answer for all our pediatric patients, because of late we are getting a significant number of syndromic babies, obese babies, and with lot of structurally compromised babies, where we need to take the opinion of our pediatric orthodontic colleagues for maxillary expansion and early dental treatment as early as 7 years of age. Unless and until we offer our best possible treatment to expand their jaws, they might develop permanent sleep apnea in the long run. And this is a very important, strong message to our colleagues over here, mainly the physician colleagues over here. Pediatric sleep apnea is not tonsillectomy and adenoidectomy always, number one. And number two, pediatric sleep apnea is a preventable problem. If we catch them young, we can prevent full-blown obstructive sleep apnea in the long run in the adult age. So dental treatment is of utmost important as early as possible by the age of 7 to 11 years of age.
How we can prevent, Dipankar? How we can prevent this pediatric sleep apnea?
Because the jaw structure, the retrognathia, overjet, overbite, these all different.
I understand. Structural abnormality needs correction.
11 to 12 years of age. Pediatric Dental Association of US, they are actually recommending to screen these babies as early as 7 years of age and to start the orthognathic treatment like rapid maxillary expansion to fitting some prosthesis. And during this 7 to 11 years of age, during their dental growing age, we can prevent development of permanent deformity. This way, pediatric OSA is actually preventable. And promotion of breastfeeding. Promotion of breastfeeding is actually indirectly contribute some kind of oral exercise, the tongue muscle development, improvement of the tonicity of the neck muscle, what we offer of late by myofunctional therapy. So breastfeeding promotion is also very important message, what we have to percolate to our pediatrician colleagues, because that is also improvement of the tone of the muscles.
I also like to add something. Actually, in pediatric patients, the way we diagnose OS is also different. For example, for adult patients, we take 10 seconds just cut off. For 10 seconds cessation of breath, we call it as a hypopnea, apnea, whatever. But in pediatric cases, the 10-second window does not work. We have to take at least 2 lost breaths. Like that is how we differently diagnose or score during polysomnography. And secondly, regarding the severity of OSA, when we use the AHI classification like apnea hypopnea index, like less than 5 and 5 to 15, 15 to 30 and above for adults. In pediatric cases, it is much different, like only 1 to 2 cases, like if the AHI is between 1 to 2, it is like abnormal and mild, between 2 to 5 and above greater than 5. So there are different, the entire way of approaching a pediatric obstructive sleep apnea patient is a bit different. Thank you.
And another point, Saurabh, basically, as because you are here, I would like to raise the issue of presence of ADHD in most of our adenoid patients, adenoid babies. So pediatric sleep apnea, because of this hypoxia or maybe because of chronic sleep deprivation, maybe they are contributing to the development of ADHD, which probably you routinely encounter in your psychiatric.
Yes, actually there is something which is even more relevant, that is periodic limb movement, restless leg syndrome and ADHD. It has been seen that there is as much as 40 to 60% overlap between PLMD and ADHD cases.
Yeah.
So I will like to comment on Dr. Dipankar suggestions and his comments. They're very well articulated, and he's on the money for the recommendation that has been recommended for sleep apnea prevention in kids. They say that if sleep apnea starts actually in the very early part of their life, so you are destined to become a sleep apneic if you are not if we are not able to detect them by the age of 7. What he's saying is that by 7 years of age, our face is designed for the rest of our lives. So if we, and it is actually in the 3rd and 4th year that the child starts to interact with the society and develops a lot of upper respiratory infections and becomes adenoid facies, and some people have responsive or hyperreactive upper airway. And in that time, a majority of us, and we have been avoiding surgeries, but for some kids this becomes very troublesome. And once they start becoming mouth breathers or they start having snoring, the problem is that most parents would not actually subject them to such big surgeries such as adenoidectomies and tonsillectomies. But if they can do it, they will prevent having a person having sleep apnea for the rest of their life. So he's very right in saying that. Another thing that he said about ADHD is that the children mind is hyper responsive. So very minimal amount of desaturation or even no desaturation triggers arousals in kids. And if the kids are not able to sleep, the reverse happens in kids compared to adults. The adults are majority become hypersomnolent, but the phenotype with kids is that they become hyperreactive and they start normally. So ADHD becomes...
That is their usual presentation.
Yeah, that's what happens. Another person asked me how...
Last one question to become one question. Yeah. Can we screen out those people of sleep apneics who have a low threshold for arousal so that we can give some benzodiazepines or some sedatives? So can we screen out?
It's a very good question. A majority of the talks in the international workshops and conferences on sleep is to identify different phenotypes. So sleep apnea or sleep disorder breathing is not when I and you started sleep medicine 25 years back, that there is snoring and there is excessive daytime sleepiness. Just like Dr. Dipankar said, kids may behave in ADHD, that the phenotype can be, there can be insomnia and there can be hypersomnia. So there can be, the phenotype could be the people who are actually complaining of insomnia because their threshold for arousal is very low, which actually happens in RERA also, respiratory effort. Right. As soon as there is a little increase in their respiratory effort, their mind triggers an arousal. So what happens is these people will always complain, doctor, I cannot sleep. Mujhe neend nahi aa raha. Because as soon as, and like I showed you one bruxism, a little bit of chatter in the teeth and they will wake up. So what will happen is these people will predominantly complain of insomnia, because insomnia is not a disease, it's a symptom. And the other people will be classically hypersomnolent. And you will see cardiovascular problems happening, like hypertension or cardiovascular problems or arrhythmia, the kind of thing, in patients who are obese and hypersomnolent or who are not able to wake up. And you will see psychiatric symptoms, malbehavior, dysbehavior, attention deficit, memory lapses in insomnic phenotypes. So when somebody actually, the question is, what you're asking is, if there is a physician who's oriented to asking one question from each patient as a ritual, how do you sleep at night? And because the people will come with different types of problems, with multidisciplinary, specialities, or general physicians, or MBBS, or MDs, or just physicians. And if they ask, how do you sleep at night? They will be able to say that, I don't sleep well. And then you start thinking, whether this patient has some kind of a sleep disorder breathing. At least we can take care of sleep disorder breathing, because the other kind of complex problems that some of the interesting cases that I showed, or Dr. Deepak Srivastava showed, they are fortunately lesser. We actually have a bread and butter cases, a lot of doctors have a tendency to call the garden variety of the obstructive sleep apnea. So, but there are phenotypes are so different that they range between insomnia to hypersomnia.
I think the audience is definitely was overburdened by this time. In fact, if we continue this, let us finish this session. Thank you, Vikram, very much for your kind presentation of cases. Thank you very, very much.
Thank you all for getting me here, and especially Dr. Saurav, Dr. Roy, Dr. Dipankar, Datta. I really enjoyed this webinar, and it was fantastic. And for many congratulations to Dr. Parthasati Bhattacharya.
Thank you, Vikram. After a long time, we met on webinar. I enjoyed your examples thoroughly. It's wonderful. Hope to see you again and again.
Sure. Congratulations.
Sure. Thank you, sir.
Thank you.
Thank you so much, all. It was a pleasure being here.
Sure.
Thank you.
Thank you very much. On behalf of the organizer, it is my ardent duty to say thanks to all. I am grateful to Arup, who has taken the whole responsibility on his shoulder to conduct such a wonderful session, and all my guests, faculty, including Subodha. The session has been wonderful. This is the 8th module of PULMOCON. We will be moving to the 9th module on next Sunday evening, which will be on intercostal tube drainage, pneumothorax, complicated pneumothorax with bronchopleural fistula and management. I hope that will be also a very interesting session, and I invite all my audience to attend that too. With that, for tonight, a big namaskar and good night.
Thank you very much.